it on? Okay. So good morning, friends, colleagues, ladies and gentlemen. Welcome to the Cardiology Summit 2016. We have the initial inaugural ceremony. We have our distinguished guest of honor, Professor Dr. B.K. Goel, Dr. Lekha Pathak. May I invite Dr. Brian Pinto, the scientific chairman and the organizer for this entire meeting, to start the proceedings. Brian.
Thank you, Uday. It's indeed a great pleasure to see so many people come up over here in spite of such heavy rains. And my thanks first to Dr. B.K. Goel and Dr. Lekha Pathak, who actually arrived 15 minutes before 10 o'clock. Also to Professor Amal Kumar Banerjee, who came in from Calcutta yesterday, Professor Sainani, who's sitting over there, Dr. Soneji, who's my teacher, Dr. Sadanand Shetty, Dr. Uday Jadhav, Ajit Desai, Dr. Akshay Mehta, really grateful. And to the two very important stalwarts who have come all the way from abroad, Professor Michael Baum, my good friend from Hamburg in Germany. He loves India. He first came to India as a 17-year-old hitchhiking, went back hitchhiking, and is both a scientist as well as an interventionist. Professor Baum actually writes in Nature, and his articles appear in many, many journals. He is extremely good at both non-intervention, intervention. And to Professor Ferrari, who will join us very, very soon. Professor Ferrari is the was the chairman and was the president of the European Society of Cardiology a few years back. Is very, very active in the field of cardiology, hypertension. So without much ado, let me tell you what we are going to get in this conference. We really have some very, very good symposia. We have the symposium starting on heart failure with new aspects which will be covered. You must have all heard about the new medication called ARNI, which is basically a drug which has come after many, many years to treat heart failure over and above ACE inhibitors, and I think both ivabradine as well as ARNI is going to be addressed by no other than Professor Baum. We also have excellent talks from Dr. Narsimhan and from Bala, who are both over here, pioneers in their fields. So we're going to have some very, very interesting debate over there. We also have the next symposium on hypertension, which is going to cover various areas like ambulatory blood pressure, resistant hypertension, and this is again, we have Professor Roberto Ferrari and C.V. Ram, who is Dr. Professor Venkat Ram, who's from the US and now in Hyderabad, who will talk to us about many aspects, and I must thank him also for coming. We then go into the lunch break. We have some luncheon symposiums which will be there, which is going to be today on the ARNI itself, which will be in Hall C, and then we go to the symposium on NSTEMI, which is basically a very, very important topic. Most of you know that NSTEMI requires a lot of debate. In fact, more patients die of non-ST elevation myocardial infarction than of ST elevation myocardial infarction, and therefore that's an important aspect. Atrial fibrillation continues to hurt each one of us, and in fact one of our persons is down with atrial fibrillation, keeps on coming to people who are a little older and causes problems in those people. So I think it's a topic that needs to be handled. Then we have the cardiac imaging symposium, which is so important to all of us. All of us know viability, all the various modalities that need to be covered. And then we close with our signature courtroom scene, where we have the doctor who comes in and is treated a patient. So today is a day full of those kind of things. We also have in Hall B a lot of intervention that will start at 12 o'clock, left main. We have CTO, we have rotablator, all that will be covered. There are going to be 2 workshops, one on IVUS and OCT, and the other is going to be on rotablator. So that's there tomorrow in Hall B. As far as Hall A is concerned, again, on day 2 we have the STEMI, we have the symposium which is there on evaluating lipids. We're going to have diabetic workshops, we're going to have valvular heart disease, stable CAD, ECG quiz. So there is plenty of great content in this conference. And we welcome all of you. We thank all of you for having come in this season. And right up over here, let me now ask Uday to come up over here and handle the proceedings for this particular symposium and call on the first chairpersons who are for the heart failure symposium and then the speakers. Thank you very much for your attention.
So let me welcome one of our most senior and distinguished cardiologists of our country, Professor Dr. B.K. Goyal sir, for the lamp lighting, Dr. Lekha Pathak, Dr. M.J. Gandhi, Dr. Amal Banerjee, our good friend Sadanand Shetty, Dinesh Parikh, and Jagdish Parikh. May I invite Mother Joanna, please, to join us here for the lamp lighting. Okay. Dr. Michael Baum, please. Michael, can you come up for the lamp lighting? Bhavesh, just take Dr. Hey, Bhavesh. So let me get the first symposium started on heart failure. And Brian, Anand and Bhavesh, can we request our chairpersons to be here? Dr. B.K. Goyal, Dr. Lekha Pathak, Dr. M.J. Gandhi, Dr. Amal Banerjee, Sadanand Shetty, Dinesh Parikh and Jagdish Parikh. Can you please come up on the dais for chairing this session? And the first speaker for today will be Anil Dhaul from Delhi. He'll speak on cardiac biomarkers implication for the future.
Good morning, and we shall start with our first symposium of the morning, that is on heart failure, and our first speaker is Anil, and I request all the speakers to stick to the time of about 15 minutes.
It's a pleasure to be here, and the rain gods have smiled on our country, creating some problems. I live in Gurgaon, which was renamed by the government to Gurugram, and it's more likely to be Guru Jam because we've been gridlocked in the last couple of days. But the flip side, somebody sent me a WhatsApp 5 minutes ago, is apparently the property prices in Gurugram have gone up 25% because everybody now has a lakeside view. So having said that, I'll just start. You know, we all want biomarkers. We all want things to tell us and give us some objective data by which we can institute therapy. So we have a multitude of biomarkers, troponins, hemoglobin, creatinine, potassium, sodium, BNPs, and there are some newer biomarkers, and there are a lot of biomarkers which are still developing, and we can take this further to microRNAs, and we can take it to proteomic biomarkers. But what we need to understand is that we need to measure something. We need to be able to understand what it means, what is the pathophysiologic mechanism, and how does it add value. For a biomarker to be ideal, it should obviously confirm or deny a diagnosis, it should be able to prognosticate, it should be a surrogate of underlying disease, it should help us in guide treatment, and the therapy should alter the levels so that we can do some kind of a biomonitoring. And how do we know if a biomarker is good? An RCT. I mean, the world is still obsessed with P is equal to 0.05, but we have a whole lot of studies, some of which are very important, like breathing not properly, for a BNP study, pride, back, improve CHF. And all this leads to our understanding whether a patient who comes to the ER when he's breathless, does he have heart failure? Because 20 to 30% of patients do not have heart failure. And what happens if we misdiagnose patients who come who do not have heart failure? Well, we can have problems because we know the nature of therapies. So if we look at a trial which was the urgent dyspnea, there was a lot of uncertainty, and BNP resolved some of that uncertainty. We felt further, and NT-proBNP resolved some of that uncertainty, and there was a score called the pride score, which we can factor. And what is this BNP? Now, BNP comes from the cardiorenal axis, where it is a natriuretic, diuretic, vasodilator, and an antifibrotic, which works in the body. And it is basically, we have the pre-proBNP, which converts to proBNP and then converts to an active metabolite of 32 amino acids, which is BNP, which vasodilates, natriuresis, diuresis. It's a half-life of about 20 minutes. It's cleared by its own receptors, by the NEP system, and by renal filtration. And it also has an inactive form of NT-proBNP, which is 76 amino acid and a half-life of about 1 to 2 hours, which is only cleared by renal filtration. So if we really look at this, by using NT-proBNP, we can get a longer idea of what things are happening, but we need to be cautious because increased neuropeptide NPs will be there with heart failure, with arrhythmias, even with acute coronary syndromes, with age, with renal dysfunction, high output states, and even things like burns and just being present in the ICU. And unfortunately, in some of our patients who are obese or who have flash pulmonary edema or even tamponade, you may not have high BNP. In some medicines, we will discuss this further. So we have an issue about the gray zone. You know, the BNP, breathing not properly study, gave us some factors, and then the NT-proBNP levels were a little different, and we don't really have one level by which we need to factor this, because the level changes, if you can see this, by age. And this is pretty relevant, and we need to factor that. Because some of these patients also have obstructive airway disease, they could have myocardial infarction, they could have pneumonias, they could also have acute kidney injury. So what confounds our BNP estimation? If your age is more, you can get higher BNP than expected. If, of course, there is an acute coronary syndrome or STEMI, you'll get a higher BNP than expected. If there's RV dysfunction or kidney disease, you'll get higher BNP than expected. If there's pulmonary hypertension, you'll get higher BNP. If there's sepsis, mitral regurgitation, it'll be higher. Obesity, flash pulmonary edema, like I already said, and some genetic polymorphisms and a burnt-out cardiomyopathy will have lower BNP than expected. The neprilysin inhibitors, which is going to be the focus of this meeting, may actually elevate BNP, and so this should not really be factored when we are using sacubitril in the treatment of heart failure. We look at chest X-ray, but chest X-ray cannot really rule out heart failure. But when we use BNP in a patient who's had heart failure for some time, accuracy is better. There is a higher negative predictive accuracy, about 90%, because it reflects ventricular wall stress. It correlates with LV filling pressure. It helps in the prognosis. And the significance of estimating prognosis is still, however, limited. You cannot give somebody an astrological figure as to how long he's going to live. So how can we use it beyond just diagnosis and prognosis? Can BNP take us into true precision medicine? Not really, because a lot of therapies can alter the BNP as we use them. For example, diuresis lowers it, ACE inhibitors, ARBs lower it, but beta blockers may transiently increase, then lower it. So all this we need to understand. It can correlate with outcomes, but it is not excellent. And natriuretic peptide guided therapy has been attempted to be used in titrating therapy to specific targets. But should we apply it? Well, the current guidelines say the therapy should be up-titrated, but an alternate hypothesis is it should be up-titrated based on the personalized physiological response of each individual patient. There are examples of this kind of thing from other areas of medicine, HbA1c, blood pressure, LDL, by which we can actually use it to guide our eventuality to cardiovascular events or death. Now, when do we measure BNP? Well, firstly, we are guiding treatment, we should measure it after several days of treatment, because it's like a WBC dropping for an infection. In anticipation of a discharge, is it right? Has the volemic peptide level been achieved? At discharge, is it used? Can we use it as a basis to judge future decompensation or therapy? It is an excellent surrogate of volume status, except when superimposed on kidney disease. Like I said, do not forget these confounders, and one of these confounders actually is obesity, which is pretty common in the population, so we should not forget it. So the trends during hospitalization can tell us how the patient is going to do, and even if we take prognosis in asymptomatic individuals, we have some data from the Framingham Heart Study. So what about the future? Can we test it at home? Yes, there are some studies which say that it can be developed as something which a patient can test at home and probably WhatsApp his physician as to this is my BNP, and if it's rising, and this was tested in the Stop Heart Failure trial, the Pontiac study, and can also be considered for primary prevention. So much for BNPs. Let's move on. What about the other so-called biomarkers? Let's look at the soluble ST2. What is the soluble ST2? It is a member of the interleukin-1 receptor family. It's actually a decoy antibody because it exists in two forms. One is a soluble ST2, one is a circulating ligand of ST2. The IL-33 binds to the soluble ST2, and when it binds to the ligand, it triggers cardioprotective effects. But if the ST2 is elevated, the soluble ST2, then the IL-33 cannot have cardioprotective effects. So it has actually been referred to as the HbA1c of heart failure, especially in patients who are frequent flyers in and out of ERs. It is not affected by age, sex, BMI, etiology, atrial fibrillation, or anemia. Beta blockers can mitigate some risk of elevated ST2, and mineralocorticoid antagonists may be especially effective in elevated ST2. So again, it correlates with BNP for heart failure admission, and it does not correlate with renal function, which is an advantage over BNP. So how do we use it? I mean, if you take two patients of heart failure, both diuresed, both admitted into hospital, similar ejection fraction, similar EKG, how are they different? I mean, they look identical, but one will do fine, the other will die. Can ST2 help? I mean, if we look at this, a patient who has a grossly elevated ST2 is at a higher risk, and this can actually outperform clinical judgment. So as levels increase, so does the risk. And the additive effect of ST2 to pro-BNP is certainly there if we add it to pro-BNP in evaluation of acute heart failure. And look at this patient, ST2 of 80, diuresed, looked better, seen in the clinic later, but came back with sudden death. Well, what was the problem? Can we use ST2 as a death marker? Well, you can use serial ST2 for guiding treatment, and you must understand that it does not have so much of variation. So a single ST2 cutoff point of 35 may actually equal risk, and it may actually be a marker for people who are not going to eventually do very well. Serial ST2 categorize responder status even in the ADHERE study. They, like I said, with beta blockers, ST2 comes back. So it has been referred to as the HbA1c of heart failure. We can put it in multi-marker panels. Multi-markers actually affect prognosis much better, and these multi-markers have been used, and it's always better to use, especially with renal dysfunction, it is an advantage to use ST2 over BNP. What about renal injury? Renal injury is very important, and if you look at the clinical characteristics, these are all our patients, 30 to 40% of patients with heart failure have renal disease. We need to look at markers of glomerular filtration, glomerular damage, tubular injury, or urinary markers. And we can have a whole host of markers, some of which I don't even understand. And they can come from a simple thing like GFR damage or tubular injury. We've been using urinary cystatin C in estimating renal function and prognosis in chronic heart failure. Glomerular damage, classically we have ascribed to albuminuria, but the important thing is tubular damage, because a type 1 CRS, which happens with acute heart failure, is something where we need to define when AKI happens. And this kidney injury can, you see, the creatinine level, which rises in acute heart failure, is a measure of kidney function, but it it does not always mean that the kidney has been injured and has lost function. So when we look at it, and we also have a lot of iatrogenic causes, overdiuresis, using contrast, antibiotics, which can actually cause. So where are the biomarkers here? When we look at coronary syndromes, we have had a whole lot of biomarkers, but when you look at acute kidney injury, we don't have too many biomarkers. So the promise of biomarkers is something that we need, and the important thing which we have come is NGAL, which is teleologically, it has been around since we were cave people. It is a protective role, and this is something where renal injury from trauma or dehydration would markedly increase expression within 2 hours as a way to heal the kidney. So this can go up by a variety of means. It correlates well, and is especially important when we are to say that a person after surgery has an increased NGAL, that this person is likely to be developing kidney injury. So this is an algorithm which we can use, that more than 350 is a high risk for AKI, dialysis, and death. It was tested in the Gallant trial, and there we can actually develop a whole lot of these biomarkers for early and accurate diagnosis, identification of patients, prognostication, and result of intervention. Remember that a rise in creatinine in acute heart failure is not really a bad sign if it is secondary to relief by congestion or treatment. I'm going to just
2
take
minutes.
2 minutes to conclude. You know, what about, so when we have to make recommendations, we for using troponin, troponin is going to be covered separately, but I'm just going to make a point that troponins also contribute to additive effect, especially in multi-marker panel. In the presence of infection, procalcitonin is absolutely imperative because there's an increased significance of bacterial infection, which can be diagnosed by having elevated procalcitonin. This likelihood arises, and it is something which can actually guide antibiotic therapy, and this was tested in the BAC study. So we can use a combination of natriuretic peptide and PCT for better diagnosis. I'm going to come to a novel biomarker, which is galactin-3. Now, this is actually a phenotypic biomarker which is related to fibrosis. I mean, even if we take this message here, that it is a mediator of cardiac fibrogenesis, and this is something which can be a phenotypic marker. It can be seen as a risk mediator or a risk marker. It also deals with fibro because it's present in 12 to 15% of population. It also leads to fibrosis in other organ systems, and this can be involved, I mean, cardiologists are relatively excited because this is something which can predict readmission, may be associated with heart failure, preserved ejection fraction, and may predict response. All this can be put together as an algorithm which we can use. We can use it as telemonitoring, as element of a remote project, and so we can use biomarkers for diagnosis, prognosis, biomarker-guided therapy, precision medicine, monitoring of disease, and a surrogate marker for class 2 trials. So these have become an integral part of medicine, and the natriuretic peptides are commonly used in the evaluation of heart failure, but their role extends beyond diagnosis, includes risk stratification, management of heart failure, ST2, and has incremental prognostic value, procalcitonin for infections, and the inability to use them judiciously has to be considered. So just a summary which you can take home is natriuretic peptides for diagnosis, assessment of discharge, prognostication, titration, ST2, but take with a pinch of salt when it comes to kidney disease, ST2 for prognostication, potentially guide therapy, HS troponin as an additive, and procalcitonin for infection. But remember that biomarkers always augment clinical judgment, and using while stupid can actually cause serious injury. So, and biomarkers will make bad doctors worse and good doctors better. Thank you.
Thank you, Anil. And we will proceed to the next
What a beautiful
lecture.
presentation you made. Your presentation was very educative and very stimulating. If any questions are there, you can ask Dr. Dhal.
I think we can have at the end actually. We'll go to the next speaker, yeah. So we have a discussion.
Yeah, next speaker is Dr. Michael Baum, and he is going to speak to us on does targeting the heart rate matter, beta blocker and evaporating.
He's doing then what are we doing? I'm busy.
So, ladies and gentlemen, dear Brian, thank you very much for the invitation to India. It's a great pleasure to be here again. And it's my task to discuss with you now, what about heart rate? And you will see in a minute, as Dr. Dahl has talked already about, that heart rate is a biomarker. So heart rate is something which can easily be measured. It's a reflection of the cardiovascular status and activity. And I would like to make four points concerning heart failure. First, does heart rate matter in heart failure? What about beta blockers, which is one of the measures where we can reduce heart rate already? Are there any problems? Is it important to further reduce heart rate with a drug like ivabradine, for instance, and what are the mechanisms of these beneficial effects? So first of all, does heart rate matter? And this is a study which has been published a couple of years ago by Professor Roberto Ferrari. He will show up here in a minute. And this shows and demonstrates that heart rate indeed has a very high energy expenditure. And you can see this extensively high numbers of heartbeats produce a lot of breakdown of ATP. And you can see with one beat, 300 milligrams of ATP are broken down, and this means 30 kilograms of ATP we burn every day. So this is not a big problem, but this causes oxidative stress, and this is a mediator of cellular aging, and therefore it propagates heart failure and another of bad conditions. So by reducing heart rate by 10 beats from 80 to 70, we save about 5 kilograms of ATP, and also we can reduce oxidative stress. So this slide shows you what is the role of heart rate. So why heart rate is important, and you can see that this is a study from the Rotterdam study, so individuals without any known cardiovascular disease. And you can see when these people are followed up for 15 years, that those with a high heart rate above 79, so around 80 is a threshold, they have a markedly increased incidence, new onset of heart failure. And this applies to women and to men. So this is epidemiology. So what about heart failure? This is a study where patients after myocardial infarction were investigated and followed up for a long period of time. So this is evident heart failure. And what you can see that those patients with a low heart rate compared to those with a heart rate of approximately 90 live, if you can take it from left to right, they live approximately 2 years longer. So this is life, this is death. And this is data from the very well-known SHIFT study, and this is a primary composite endpoint, cardiovascular death and heart failure. And you can see that those patients with a heart rate of 70 could be lower, but 70 compared to those with a heart rate of 87, they have only half of the event rate concerning hospitalization. This means one heartbeat more or less accounts and translates into a 3% event rate in the following year, and also 5 beats to approximately 16% events. So it is a very easy and, by the way, very cheap biomarker in patients with heart failure. So this is stable heart failure, and this is heart failure in patients who are discharged from the hospital after a decompensation. And again, the same picture, those with a heart rate above 80 have a very much higher readmission rate and mortality rate in 1 year compared to those with lower heart rate. So the first message is heart rate does matter concerning outcomes in heart failure. So what about the exercise tolerance when a patient has a low heart rate? And we looked at this in pacemaker carriers, and you can see in these patients, this is a normal individual, the pacemaker rate was increased during exercise. And you can see easily that the uptake of oxygens is paralleled by this increase of heart rate. However, looking at an individual with heart failure, it is quite different. You can see that heart rate, you can increase heart rate. The threshold and exercise tolerance is lower. However, from a heart rate of approximately 80, the curve flattens. So you just have a high heart rate, which does not contribute to cardiac output, which is here shown as a maximal uptake of oxygen. So heart rate matters concerning exercise tolerance and outcomes in heart failure. It might be predictive of new onset of heart failure in the general population. Second question, what about beta blockers? Do they work by heart rate reduction, and are there any problems? So this is the meta-analysis shown here, where you can see that when heart rate is lowered, This every dot here is a beta blocker trial in 20,000 patients. You can see that there is an increase in ejection fraction. However, does it translate into a clinical benefit? And this is shown here, change in heart rate and risk reduction in mortality. There is a fair correlation of heart rate reduction and an increase of risk reduction. However, when you look the heart rate achieved here, you can see that the majority of the beta blocker trials only reduced heart rate to approximately 70 beats. So we do not know what happens below 70. So therefore, this meta-analysis points clearly to the point that if you look at different predictors of the life-prolonging effect of beta blocker, nothing was significant except one thing, and this is heart rate reduction. And this is more important than beta blocker dose. So it's a biological action of the beta blocker rather than the dose itself. So this is how they work, approximately to a large portion by heart rate reduction. Do we need a further heart rate reduction with beta blockers in the light of the fact that only heart rate is reduced by 70 beats per minute by beta blockers? And these are indeed three registries from the IIFC, from Italy and from France. And you can see that patients who are treated with beta blockers, so regular treatment of heart failure, they still have in approximately 50% of the cases a heart rate above 75 or 80. So despite beta blocker treatment, heart rate is still high. And when you look at here at those with different heart rates, the amount of beta blocker treatment is similar. And this points to the fact that indeed heart rate is regulated independently of beta receptors. And this is a direct effect in the sinus node. So how can we influence this? And there is one drug which is called ivabradine, which is a specific inhibitor of this current, the so-called funny current. And what you can see that the drug here is producing a flattening of the spontaneous depolarization in the sinus road. And this is the only action of ivabradine. And by reducing this phase 4 phase of the action potential, you can see that this results in heart rate because the threshold for a full depolarization is achieved later. Furthermore, ivabradine binds only to the open stage of the channel. And this is a situation where heart rate is high because these channels are activating. So the high heart rate produces stronger effect than the low heart rate. And this is clinically important when you look at this. Patients with a heart rate about 60 do not have a further reduction of heart rate, while those at a heart rate of approximately 100, they have a strong heart rate. We call this use dependence effect. And due to these pharmacological properties, a trial was done, which was the SHIFT trial, either assigning patients to ivabradine or to placebo. About 7,000 patients were investigated, and these were the results. By reducing heart rate in patients in sinus rhythm at an ejection fraction smaller than 35 or equal than 35, there was a reduction of heart rate by 11 beats to 64, which relatively remains constant over the full period of time. And the results are the following. There was a nominally 18 relative % reduction of the primary composite endpoint, which was cardiovascular death and heart failure. So looking at the different endpoints here, you can see that they all go into the right direction. There is hospitalization for heart failure was the main target of heart rate reduction here, and all the others go in the right direction. In particular, heart failure death was reduced by 26%. So starting from 70, further reducing heart rate is apparently important. So how is the optimal heart rate? And here we looked at the heart rate on ivabradine after uptitration and followed up these patients. So in those patients who have a heart rate below 60 had the best prognosis, and those who stayed on a heart rate above 75 despite treatments with beta blockers plus ivabradine, they have twice as high event rate, indicating that in heart failure patients the optimal heart rate is something between 50 and 60 beats per minute. And when you then adjust the reduction in heart rate by the heart rate reduction, you can see that indeed it comes close to 1. It is effect due to heart rate reduction. So what else? I mean, there are different thresholds for endpoints. This is the association of hospitalization for heart failure to heart rate. You can see a linear relationship over the whole spectrum of heart rates. Why there is a threshold for cardiovascular death? Only there is an increase at 75 beats and higher. So we looked here in the subgroup of patients with a heart rate above 75, and here you can see a significant reduction of all endpoints, including cardiovascular death, all-cause death, and all kinds of hospitalization. And the effect is big because when you achieve a heart rate reduction by 15 beats, and you can go below 15, you can reduce the event rate by approximately 50 or more % compared to those who have a low heart rate response on these treatments. So heart rate needs to be low, and the question now is, and this was asked frequently, if a patient has a high load of comorbidities, is it dangerous? Or is the mortality carried by different things rather than heart failure? So therefore we looked here in different comorbidities like elderly patients, severe heart failure, COPD, renal impairment, and all kinds of comorbidities. The treatment effect was maintained. In multimorbid patients having multiple disease, here we looked into 1, 2, or 3 comorbidities, and you can see that comorbidities have a huge effect on outcome. Yeah? This is 3 comorbidities and more, 4 and more comorbidities. Again, a very strong effect. And however, the treatment effect was maintained in all instances. So why is heart rate reduction working? In the end, I will show you a couple of slides on the mechanism. So this is an experiment carried out in 1871 by Henry Pickering Bowditch. He is the founder of the American Society of Physiology, and you can see that heart preparations driven at a high heart rate have a high contractility, and low heart rate have a low contractility. This is called the so-called Bowditch effect or positive Treppe effect, staircase effect. You can see that this is here an old experiment of our group looking into heart failure patients, isolated papillary muscle strips. When you pace them at a high heart rate, they go up in contractility, and relaxation is a little bit disturbed at high heart rates above 120. However, when you look at the same experiment in patients with heart failure, you can see a decline in contractility. So there it becomes evident that when you reduce heart rate, you increase the performance of the myocardium. So why is it so? You can see that in dilated cardiomyopathy, this is a calcium transient. There is an increase in diastolic calcium, and this impairs at high heart rates relaxation. So diastolic dysfunction is related to heart rate. And for the next beat, because it is all sticking in the sarcoplasmic reticulum, there is less calcium which can be released. So systolic calcium is low, diastolic calcium is high, and this causes systolic dysfunction. So both of them are related to calcium and heart rate. So therefore, what is the safety? It is safe. It does not reduce blood pressure, which is important for patients in higher classes of heart failure. And the reason is that when you reduce heart rate, this is an Italian study, then you increase stroke volume due to the reversal of the negative force frequency relationship, and cardiac output remains stable and remains sustained. So taken together, heart rate predicts outcome in heart failure, a little bit also exercise tolerance. A heart rate reduction reduces outcomes like hospitalization primarily. It works through all comorbidity subgroups. It has acute and chronic effects of contractility because there is an improvement of ejection fraction. It has a safe hemodynamic profile. It does not reduce blood pressure, and it has a plausible pathophysiological mechanism. So the conclusions and the 2 questions I was asked is, heart rate matters, targeting heart rate in heart failure also matters, and heart rate has turned from a risk marker in heart failure, but in none other conditions, to a risk factor because it can be modified by heart rate reduction. Thank you very much for your attention.
Thank you, Michael, for your excellent deliberation on the importance of heart rate in the context of heart failure. Now I invite Brian Pinto, under Okay, Uday Jadhav, speak on iron deficiency.
So
You speak
you-
on iron deficiency?
That's
Okay.
right. You have a different brochure with you. The program got changed, so I have replaced Brian for iron deficiency anemia.
Okay.
Okay. Let's hope I make a job of it because I've replaced Brian. Thank you. And let me start with what do we have in, I have not said iron deficiency anemia. I'm just saying iron deficiency in heart failure. What are the current trends in medical management? This is how we'll take it forward. Why does anemia occur in heart failure? Is it really an issue? If so, is it common in India? Are there trials that show the benefits for anemia correction? And do we have some recommendations henceforth? We have a lot of clinicians here, and this topic has become extremely crucial. It's way back in 2013 that Franz Ruschika said this, that we have already reached probably the peak of targeting heart failure therapy, including the RAS inhibition. And the administration of intravenous ferric carboxymaltose may be a new concept which will help in this patient. So let's take it forward from here. How do you define iron deficiency? We go by the 2012 guidelines saying that if the ferritin is less than 100 nanograms or it's between 100 and 300, 300 is the cutoff for normal, provided the transferrin saturation is less than 20. You may focus attention on this because it should become important the way we diagnose anemia. The reason why we should look at this carefully in heart failure segment is the symptoms are pretty the same. You have shortness of breath, fluid retention, palpitations, cognitive problems. Interestingly, patients who are anemic in heart failure also have lightheadedness, pre-syncopal episodes, at times tinnitus in the ears. So these are some of the symptoms that we keep in mind. Is iron deficiency important? Yes. Iron is concerned with the myocardial metabolism. A deficiency would work in terms of lowering the mitochondrial enzymes, so the respiratory chain enzymes would go down. That would affect the ATP synthesis. So you have both a reduced oxygen delivery, a reduced oxygen utilization, and therefore the PVO2, the oxygen consumption, also goes down. This is an important concept that we need to understand. And even if anemia is absent, now we don't look at clinical anemia, we say even if anemia is absent, as you can see, the down one is no iron deficiency and no anemia, and then as we go further up, we say no iron deficiency and anemia, iron deficiency and no anemia, and of course iron deficiency and anemia itself. So as we look at this whole graph, you can see the increase in the mortality. Iron deficiency and anemia both are important. What happens in heart failure is the trigger. So you have hypoxia as one of the stimulants. You have the erythropoietin signal, decreased absorption from the duodenum in heart failure, patients with the duodenal and the small intestinal congestion, the inflammatory signals, all of them are going to play its role in the way hepcidin and the phosphopoietin is going to be released by the liver. And that's where you can see that the bone marrow will produce lesser and lesser ferritin. That's the whole concept of how anemia occurs in a patient of heart failure. Okay, so let me show you a couple of new publications. One has just come in JAMA Cardiology. What is the prevalence using various definitions? And here is what it showed, that a lowered hemoglobin and a lowered serum iron are independently associated with all-cause mortality and cardiovascular mortality. Both are important. This was observational studies of more than 4,500 patients. Anemia was seen, as we see in clinical practice, in 1/3 of the patients, of which 2/3 had iron deficiency, 1/3 did not have iron deficiency. Both anemia and markers of iron deficiency, except ferritin. Therefore, we should look at interest now what is going to happen in the future. This was one study where actually ferritin was not shown, the drop in ferritin level, to be associated with morbidity and mortality. The serum iron concentrations was less than 45 micrograms in about 15%, less than 67 in 36.6%. In India, we have serum vitamin B12 deficiency very common. You see that in the health checkup reports. This was a study, I think this is the only study I looked at, which looked also at vitamin B12 and folate concentrations and did not show that the cardiac phenotype of heart failure really correlated with it. So B12 folic acid deficiency did not. Actually, the prevalence of anemia increased slightly with the higher rather than lower B12 and folic acid concentrations. The one category that we would like to look for is hypoxia. What about Indians? I mean, this is a slide from the nutritional journals, but it's still important that the iron absorption reduces after taking black tea by close to 75 to 80%. Not the green tea, not the peppermint tea, but mainly it's the black tea. The factor associated with tea drinking are the other dietary factors too, including the phytate and the coffee in the milk. Microcytic anemia among tea drinkers is much greater than non-drinkers. So what can be done is that one can have tea and meals at different times so that the interaction doesn't occur. And here is the iron food in Asian Indians. What do we eat and what do we have? Most of the predominantly heme iron comes from the non-vegetarian products. There are vegetarian aspects which you can look at. For example, pumpkin, spinach, red kidney beans, tofu. You may have looked at the Jack heart failure issue last month, which showed just 70 ml of beetroot consumption daily, 70 ml of beetroot consumption daily, decrease the symptoms and the morbidity and hospitalizations from heart failure. And the reason is so very interesting. When beetroot is consumed, it gets absorbed through the intestine, and then it mixes as its secretion with the salivary content. The beetroot has inorganic nitrites. They get converted to inorganic nitrates. They get reabsorbed in the intestine, and then at the vessel wall, they release nitrous oxide. So that's the way vasodilation helps. This is an excellent sort of contribution of what diet can make in terms of iron deficiency in heart failure. So how do we correct it? You have IV iron sucrose, which was used long back. That's a very old story. And there have been clinical trials. There have been fair heart failure trial where Ferinject, which is the patent by the way, that's why I've quoted it, ferric carboxymaltose was used. And what they found is in these patients, it increases the patient global assessment as well as the quality of life. It also changed patients who were in an NYHA class. So 50% of these patients who had an NYHA class which was advanced came down to a lesser NYHA class in terms of tolerance of exercise and the way they lived their life. The second study was confirmed heart failure, which looked at giving intravenous iron in heart failure. The study was done in order to look at a longer follow-up and exceeding a 200 milligram dose. So now we are looking at a 1000 milligram dose. And the confirmed heart failure, again, it was a multicentric study, 9 countries, 41 states, and it showed a increased improvement in the walking exercise test. It also showed improvement in the quality of life, and it made a significant difference on the hospitalization. So the hospitalizations, as you look at the last chart. Now, what does this predict for us? That actually the mortality and deaths may not change, not at all in the short term. There could be some impact in the long term. But the hospitalizations went down significantly, as much as 61%. So we have a salutary effect of giving intravenous iron. Okay. Now let's look at a very important paper that just published a week back in the European Journal of Heart Failure. This comes from Stefan Anker. They found that in stable heart failure, there is the iron deficiency is existent in 50% of the patients, in 46% of the non-anemic patient with stable systolic heart failure, and the clinical endpoints, that's death or cardiovascular morbidity, mortality did not change. We do not know as on now whether simply giving an intravenous iron will make a difference to the long-term outcomes in terms of death. Having said that, hospitalizations for heart failure will certainly go down, and the quality of life will improve. So intravenous iron therapy reduce the risk of combined endpoint of all-cause deaths or cardiovascular hospitalizations, heart failure 31%, NYHA class changed by 50%. It increased the 6-minute walking test distance and improved the quality of life. And this shows the aspect of how you look at systolic heart failure symptomatic with preserved ejection fraction, with symptoms, without symptoms, no heart failure. And you look at the systolic heart failure up, and we see that at all grades of anemia, the prevalence is highest in the systolic heart failure as compared with patients with preserved heart failure or patients who are asymptomatic. All right, so there are plenty of trials which are likely to come in the future. One thing is there is a trial called as the Practice Asia Heart Failure Registry. They will enroll patient, whatever be the class of NYHA. Irrespective of the class of NYHA, we'll see what happens when intravenous iron is given to Asian patients. The last one but very important slide, or I think that's the last slide, is serum iron has not been mentioned, really speaking, in clinical trials to assess heart failure segment therapy. It's serum ferritin, but I already showed you the JAMA paper saying that may not be as relevant. If you look at the sensitivity and specificity to assess iron status, serum iron is pretty low. As you go down to transferrin, ferritin, transferrin saturation, that gets better, 59 to 88%. But what is very relevant is a very simple thing. You still look at hypochromia of the red cells. That's a simple parameter on the blood smear. If it's less than 2.5%, the sensitivity is 65 to 80%. And the specificity is also close to 80%. So this very simple thing that we look at the lab report, just the hypochromia of the red cells, is a great predictor of telling you what will happen to these patients. 2016 guidelines have already said in the heart failure, the last slide, serum ferritin, transferrin saturation, and total iron binding capacity should be measured in all patients of heart failure as a comorbidity. This is a 2016 ASC guideline. And intravenous ferroxycarbomaltose should be considered in symptomatic patient with reduced ejection fraction whose serum ferritin is less than 100, or if the transferrin saturation is less than 20, between 100 and 300, it should be administered as a 2AA indication. We really don't have anything different besides. I mean, if you look at the erythropoietin stimulating drugs, erythropoietin, darbepoetin, we have concerns. They have not really shown to change the morbidity or mortality. In fact, there have been concerns about increased incidence of hypertension, off-target effects. So we really don't have anything to offer to the heart failure patients. What we have in hand today is to give a ferric carboxymaltose. Thank you for the time.
Thank you, Uday, for a very important message that we should not ignore the anemia in patients with congestive cardiac failure. Now we move on to another topic. That's a very important topic, RAS blockers and beyond, probably the azilsartan. May I invite Dr. Michel Baum to please deliver his talk.
So thank you very much again. So I'm about to talk about RAS blockade and beyond. And what was most intriguing is the development of a new guideline. So this is the old guideline where there was a very strict algorithm of heart failure therapy, starting from diuretics over RAS inhibition to the other things down here, which is ivabradine, and also then the device therapy. So this guideline and treatment topic has completely changed. Now we have diuretics which can be modified and instituted all over the journey of a patient. And we have here also the innovations in this, and this is the extension of the RAS inhibition called this ARNI concept, which is angiotensin receptor blockade. And and neprilysin inhibition. So this is the medical therapy. So it starts with ACE inhibitors, and the first thing what is new, that we do not start with an ACE inhibitor and then add a beta blocker. Now it became possible to combine both in the very beginning. Then the next step is a mineralocorticoid antagonist, and then here you can go to the new therapies, which is the ARNI or heart rate reduction. So what is not new was the evaluation of the different drugs. They all have a class A1A judgment in the guidelines, ACE inhibitors and ARBs, if ACE inhibitors are not tolerated, beta blockers and ARNIs. But the new thing here was that indeed it can be early combined, and the evidence for this was a CBIS-3 trial, which was published a couple of years ago, which randomized patients either to bisoprolol and then followed by an ACE inhibitor, or to an ACE inhibitor followed by a beta blocker. And these were the results. It is completely, it doesn't matter whether you start with an ACE inhibitor or with a beta blocker, the event rate is exactly the same. So you can start with either of the drugs, and this is the intention to treat and per protocol analysis. So this was based on a rather old study, but it was newly introduced into the guidelines. So there are some differences, however. Usually there is some little bit of a benefit of beta blockers when beta blockers are started. However, when a patient has a more severe heart failure, the incidence of worsening of heart failure was slightly more pronounced with a beta blocker. So it's an individual decision, but a beta blocker should be given together with an ARS, or when an ARS is already present but not alone. So this is the first innovation. There is nothing new with the mineralocorticoid antagonist, and this is based on these well-known studies, the RAIL studies in severe heart failure and the EMPhASIS study in stable heart failure. So, however, this was now challenged by a new development, and this is depicted here. So this is the pathophysiology of heart failure. We know that in heart failure, all the vasoconstrictive, maladaptive mechanisms are overwhelming the protective ones. You can see that ACE is upregulated, and this produces hypertrophy, vasoconstriction, and sodium retention, and there is a counterplayer, which are the aterionatriuretic peptides, which produce exactly the opposite, vasodilatation. They increase sodium excretion by increasing the perfusion of the kidneys, and experimentally they have protective effects. However, these beneficial mediators are broken down by an enzyme called neutral endopeptidase, now called neprilysin. And this enzyme is located here on endothelial cells, but these are also shedded into the circulation. And there was one investigator in Spain who looked at the activity of the neprilysin, which is able to break down the natriuretic peptides, and these were the results. So there was the endpoint cardiovascular death and hospitalization and cardiovascular death was worse when the activity was above the median compared to those patients with a lower activity. So patients who have a high activity of neprilysin constantly breaking down these beneficial peptides have a worse prognosis. And therefore, this is not only some enzyme, but maybe a key player and pathophysiological relevant mechanism in heart failure. So the idea is to inhibit these maladaptive enzyme and to inhibit the maladaptive AT1 receptors, thereby enhancing these adaptive proteins in the circulation. And this was done by a salt complex which was called initially LZZ696, which is a combination of the AT1 antagonist valsartan and the neprilysin inhibitor sacubitril. So this is an enzyme which is this is an inhibitor which is split in the mucosal membrane and always has a stoichiometric relationship of 1-to-1 in the circulation, and this produces both the inhibition of the AT1 receptor and the inhibition of neprilysin. So indeed, this is the recommendation in the guideline. You can see this is depicted in green. This means this is a class 1 recommendation. Yeah, unlike ivabradine, which is a class 2A recommendation because cardiovascular death was not reduced, only heart failure hospitalization. So therefore, this is a class 1 recommendation. And in the American guidelines, it was even set at the same stage as ACE inhibitors and ARB. So why was this done? It's a very high grading. And this was based on the paradigm study, which investigated LZZ compared to enalapril after a run-in period. So this was the largest trial in heart failure ever, and the comparator here was enalapril, and this was chosen because enalapril indeed is the only drug in the SOLVE trial which reduces mortality, and not an AT1 antagonist, because this is just a reserved drug for an ACE inhibitor and does not cover the whole population of heart failure patients. So why is zacubitril combined with an AT1 blocker and not an ACE inhibitor? And the reason is the following: because the neprilysin also breaks down angiotensin II. So in combining an ACE inhibitor and not a blocker would be antagonized by the effect of neprilysin. So indeed, the combination to the zacubitril has to be an AT1 blocker, otherwise the effects are phagocytizing themselves. And these were the primary results. You can see that the combined endpoint in cardiovascular death and heart failure was reduced by 20% with a very low p-value, as you can see here. Both components of the primary endpoint, death from cardiovascular causes and heart failure hospitalization, they're reduced in a similar way, unlike in the SHIFT trial. So there is homogeneity between both of the components, and therefore it's a class 1 recommendation. So this comes with a price, and this is what happens concerning safety. The safety issues are very low, but there is a more significant reduction in blood pressure, as you can see here. It is considerable also on an ACE inhibitor, so it's a little bit in the discussion overrated. However, there was a significant difference. 14% of patients developed symptoms of hypotension. On the other hand, it produces less renal function decline. And this is due to the fact that the natriuretic peptide increased perfusion of the kidney. So the increase in creatinine and the drop of GFR was smaller on LZZ compared with an ACE inhibitor. And there were also less hyperkalemias and less coughing because it's an AT1 compared to an ACE inhibitor. So now you might be intrigued by the question, and we have it available since 8 months now in Germany. What about blood pressure? And this is what physicians are concerned. So low blood pressure is associated to a worse prognosis in heart failure. So what happens to a drug where blood pressure is low? So this paper is submitted and will hopefully be published soon. Here we looked at the different groups of blood pressure at baseline. So this is a blood pressure where you start treatment below 110, 110 to 120 and higher. And what you can see that even in those patients who have a low blood pressure, the Kaplan-Meier curve for LZZ is below enalapril. So also these patients do benefit. And you can see that over the whole spectrum of blood pressure, all patients do benefit the same because the interaction p-value is neutral. So what can you expect here for concerning blood pressure? There is blood pressure hypotension occurring in 13–14% on enalapril, 25% when the blood pressure is low on LZZ, and in blood pressure above 140, these effects are 4–8%. So blood pressure reduction is more pronounced, but if you are able to get into the drug into a patient with low blood pressure, you have the same benefit. And please note that patients who have to discontinue the drug was only 1.3 and 1%. So what was done in the trials, they reduced the diuretic dose because most of the patients were overdosed with diuretics, and they reduced all nitrates and calcium antagonists, which do not modify the outcome of heart failure. Another argument of physicians is when the blood pressure is lower or lowered on treatment, patients feel worse. And this is another set of data in the paradigm trial. quality of life was very thoroughly investigated by this KCCQ score, Kansas City Questionnaire for Heart Failure, and you can see that in all domains, physical activity, physical well-being, quality of life, there was a beneficial effect. So we looked at this in the low blood pressure group, and even when the blood pressure at baseline is quite low, patients do benefit from this treatment concerning their quality of life. So what about the different stages of heart failure? We are asked quite frequently who should be treated. And this was done here in a further secondary analysis, which is the score, the MAGIC and MACE score, one from a registry, one from a trial. Severity of heart failure. You can see the majority of patients were at intermediate risk. However, over the whole spectrum of risk, there was a benefit of LZZ. Therefore, there is no evidence that any subgroup improves more or less than any other subgroup, and the same is done here with the emphasis heart failure risk score. No evidence that there is a subgroup who does not benefit or has a particular high benefit. So particular scientifically, the whole population of symptomatic heart failure patients are suitable for treatment. So what about the markers? Dr. Dell referred to it, that BNP can indeed be influenced by treatments. And this is here the mechanism you have seen in his talk already, a similar slide. BNP here is broken down from pro-BNP into BNP and anti-pro-BNP. Anti-pro-BNP is not a substrate for neprilysin, while BNP is cleaved, indicating that this is a marker which is not affected, and this is increasing on treatment. So this is here shown in the trial. There is a reduction of anti-pro-BNP, which is a reflection of improvement of heart failure. And below you can see there is a tiny increase of BNP. And therefore, you can see that both might be reduced due to heart failure improvement, but on treatment there is an increase of BNP, and you cannot say, is it the drug or is it deterioration of heart failure? So please do not use BNP anymore. This pro-BNP is the right marker and not BNP anymore. So how do you switch patients? This is important. There was one trial which was done with omapatrilat, and you have patients with omapatrilat with an ACE inhibitor and a neprilysin inhibitor who have indeed angioedema. So this is due to the fact that when you inhibit both, you inhibit a whole variety of enzymes producing CAF by biogenic peptides. With LZZ, you only inhibit NEP. And therefore, you have to stop, wash out for at least 36 hours an ACE inhibitor before you go to LZZ. When an AT1 is on board, don't care, just change directly, because this can happen. This is a patient on enalaprilat, which looks not very impressive, but it can happen that this is occurring. This is a patient from our clinic who has a Quincke edema, which is very severe and often requires intensive care treatment. So what is in the pipeline? In the pipeline, this is frequently asked, what about preserved ejection fraction? And indeed, there is a study, the Paragon study, looking of LZZ in HFpEF, which is not an evidence treatment now, but it has to be scrutinized. This will be done in Paragon. There are developments for a once dosing. It's now a 2 daily dose drug. And furthermore, there are resistant hypertension studies which are starting now. So again, take-home message, it's a true innovation. It reduces cardiovascular death and heart failure hospitalization, 2 components of the primary endpoint. It was the largest trial ever in the heart failure arena. It improves quality of life, and it is safe in subgroups, in elderlies and in many other subgroups, and of course in patients with low blood pressure. Thank you very much for your attention.
Thank you, Michael. Friends, all of you would agree with me. Michael gave us the extreme, the detail on ARNI, since we are going to get that soon. So he has given us very clear concept and how to use this drug. The next I would like to invite Dr. Narasimhan, who is going to speak on CRT, cardiac synchronization therapy, who are the patient and how to select, and who will be benefited in heart failure. Dr. Narasimhan.
Good morning. Thank you very much for the kind invitation. Can we have the slides, please? The patient selection in CRT is extremely vital because it's an expensive therapy, and very often there is a misconception among both practicing cardiologists and physicians. Either this therapy works or it doesn't work because of several factors. I would like to highlight why in a given patient, despite having all the best of the quoted indication, you may not have a good response. On the other hand, the patient doesn't fall into the conventional guidelines and they still may respond. And there is more to CRT than dysynchrony. Let's start with a case. This is a 50-year-old gentleman with prior history of anterior MI, ischemic cardiomyopathy, class 3 heart failure, repeated hospitalization for heart failure. Because of a sick sinus syndrome, he was on a dual chamber pacemaker, which was implanted about 5 years ago, and he was coming with repeated episodes of heart failure. So what would be the next therapy? Upgrade it to ICD, dual chamber, switch on the minimize the ventricular pacing. Would we upgrade it to the CRTD, or would we consider for a cardiac transplant? We'll revisit this case, and then I'll show you some of the evidence behind the guidelines that were put together. Now, if you take patients with heart failure and a wide QRS, there are distinctly two phenotypes. One are the patient with a left bundle branch block, and if you look at the benefit of CRT, right from 120 milliseconds QRS duration, there is a significant reduction in morbidity and mortality in this subgroup of patients. On the other hand, if you have a patient with a wide QRS, which is of a non-LBBB morphology, IVCDs, indeterminate access, right bundle branch block, there is no mortality benefit till such time the QRS widens beyond 150 milliseconds, which led all the guidelines, both the American and the European guidelines, to come up with this, that patients with a left bundle branch block and a QRS duration of 150 millisecond and above, it's a class 1 indication, and for such of those with 120 to 150 millisecond, it's class 1B indication if the morphology is left bundle morphology. On the other hand, if you have a wide QRS of a right bundle morphology or atypical IVCDs, unless the QRS duration is more than 150 millisecond, you don't have a distinct clinical benefit, and that is the reason why it is a class 2A indication in the European guidelines. Non-LBBB patients with 120 to 150, the class level of evidence is 2B, and QRS duration of less than 120 millisecond is a potential for harm, and therefore it is recommended not to implant a CRT there. So if you look at the practice guidelines, there is a mortality benefit when you implant a CRT with a defibrillator for such of those patients who have a left bundle branch block at a QRS duration of 130 millisecond and a depressed LV function. On the other hand, when the QRS duration is more than 150 millisecond, even right bundle branch block patients may benefit more often by reduction of hospitalization rather than mortality driven endpoints in these subset of patients. Ann Curtis came with block heart failure trial, which looked at patients' impact of pacing the RV versus CRT in patients who have a regular indication for a pacemaker. And that that was the reason why whenever you upgrade a pacemaker or an ICD in a patient with heart failure, and you think that the percentage of ventricular pacing is going to be more than 40%, it's better to consider a CRT in these patients, CRTD. Similarly, if you have a person when there is a de novo implantation for a pacemaker, you should consider if they have a low ejection fraction and they are going to percentage of ventricular pacing is going to be high, you should consider CRT right up front. The title of the talk was How to Select the Best Responder. Now, this is again the framework. Most of the clinical trials have indicated that wider the QRS, greater the clinical benefit. Left bundle morphology, greater the clinical benefit. For some reasons, across the board, several trials have indicated this gender bias, that women, even with a narrower QRS, about 120, 130 milliseconds, show a greater benefit for CRT compared to the men. Non-ischemic cardiomyopathy, they respond better, and patients with narrow QRS, non-LBBB, do not do well. In fact, you can potentially harm these patients. And you have a group of patients who do improve to some extent. They are not the super responders. They are men with ischemic cardiomyopathy and LBBB in morphology. Now, let's tease out the evidence. Should we condemn all the right bundle branch block patients that they are not candidates for CRT? Let's go back, and this is the wide data that has been published among patients with left bundle branch block. If you go and implant CRT in every single LBBB, about 85% of the patients are likely to respond. That is 10 to 15% are non-responders. If you take right bundle branch block patients, you will have about 40% of the patients still will respond even though the morphology is right bundle. So it's not that all the right bundle are going to be non-responders. So as a clinician, in this subset of patients with right bundle branch block and IVCD, you are still likely to see about 40% of the patients who are likely to be responder. Please understand, we practice clinical medicine. It's not all or none. You can't say right bundle, they don't respond, left bundle, they always respond. Let's look at this. These are two distinct patients with right bundle morphology. On the top panel is a patient with a right bundle branch morphology with a left axis deviation and similar QRS duration in both the patients. This patient is a hyper responder and this patient is not a responder. Why? You look at the S waves in lead 1. Now, S wave in lead 1 in a patient with a left bundle branch block, see right arm lead, left arm lead. If the left wavefront is moving away from my left arm, it means there is a delayed right ventricular activation. On the other hand, if that S wave is not there, it's a masquerading bundle branch block. In other words, this patient has a diseased right and left bundle, but the conduction is slower in the right bundle far more than the left bundle, and therefore you have this kind of a morphology on the ECG. So one clean takeaway is, if you have a right bundle morphology with a wide QRS and no S waves and extreme axis shift, you should still consider CRT in these patients. Now, having said that, even the best of patients, you have seen a patient with a LBBB, all candidates, everything is fine. You refer the person for a CRT. I'm sure most of you would have seen an occasional non-responder, despite sending the best of the patient. Why is that so? This is data from Cleveland Clinic, which looked at about 30,000 patients of a pooled data of patients who do not respond to CRT. And what are the commonest reason for patients not responding to CRT is improper programming of the AV timing and a significant arrhythmia in these patients. And of course, all the other comorbidities which we heard about in the previous talk. This is very relevant. Unlike a regular pacemaker where you want to minimize the ventricular pacing, for a CRT to deliver therapy and improve the cardiac output and show reduction in morbidity and mortality, you should pace the left ventricle 100% of the times. If you minimize it for some reason, you're not going to have the benefit of CRT. Let's go through this. This is a patient with improper AV timing. You find that there is a single filling wave in the ventricle. Once you optimize the AV delay, a good diastolic filling, patient feels better because the lungs are decongested, patient feels better, and that translates into clinical benefit after programming the simple AV delay in a given person. Now, are we talking theory about this? This is Kaplan's data looking at the percentage of ventricular pacing and the amount of clinical response that the patient has got. So if you take a patient who has got a high degree of left ventricular pacing, 95% of the times 360 days of 365 days, he is continuously LV paced. That is the survival, compared to patients who have less than 80% of the time their ventricular pacings. So even losing 20% of LV pacing in a day, whatever be the reason, the rates, improper programming, atrial arrhythmia, ventricular arrhythmia, you lose the left ventricular pacing, you lose the clinical benefit. So this is again, what are the common reasons? 90 commonest reason is atrial arrhythmia for loss of CRT, AT and simple atrial fibrillation, atrial flutter, you lose the benefit of CRT. Once there is a PVC, for several cycles after the PVC, there is calcium loading and there is improper programming, you can lose the benefit of CRT. So please understand, you can have the best of patients, and unless you tweak these things and constantly see the patient as a clinician, you are likely to miss the clinical benefit in a given patient. And one important fact which is often ignored is the importance of the LV lead placement. Unfortunately, even the best of journals accept this. After the prospect trial came, there is a wave of belief that the echocardiogram does not contribute to patient selection. Nothing can be farther from the truth. If you look at about 30% of patients on prospect trial received a LV lead which is not pacing the ventricle at the latest portion of the ventricular activation, but rather than the initial activation area, in which case you are unlikely to have any benefit. So the simple tool, if you are an implanter or a cardiologist, is please look at the LV sensed electrogram. It should be at the end of the QRS for you to get the best benefit, because you need a wavefront which starts from the RV and LV and gets a neat fusion so that you get the best benefit of CRT. Now, am I talking theory? Is there clinical evidence for this? Let's look at this target trial, which looked at the mortality. This is a very elegant trial taking just about 250 odd patients, where they randomized to patients to target the lead placement at the site of the latest ventricular activation as determined by speckle tracking. So if your lead was in the area of the latest activation of the ventricle, you have a 2-year survival of close to 95% in a class 3 heart failure. On the other hand, if your lead is put somewhere in the left ventricle, which is not at the latest area of activation, you have a mortality as high as about 30%. So this is not theory. Even a small trial of 200 patients had shown a significant a priori hypothesis that delivering the impulse at the latest site of activation matters in terms of mortality and reduction of heart failure hospitalization. What are the other factors? Simple fact is, patients come with diseased ventricle. They may have a left bundle branch block, but if they have a circumflex infarct and that latest area of activation is sitting in a scar, pacing the scar is the worst thing that you can do for an electrophysiologic substrate. You increase the rate of arrhythmias, increase dispersion of refractoriness, and therefore there is an increase in mortality if you put a lead in a scarred area of the ventricle. Look at this. When there is no scar, their survival is excellent compared to persons where the lead was implanted at the level of the scar. As an implanter, how do you know? Very simple. Just measure the bipolar electrogram from the LV lead. Scar produces low voltage. If you have a low voltage at the sensed electrogram, you know that the lead is sitting in a scar. Do not accept that position. Go to somewhere else. Now, what are the other things that you can tweak up on? Is the latest data that looked at multi-point LV pacing, meaning pacing the LV from more than one site, one and proximal most area, further augments the cardiac output, and there is initial result to suggest that at least in a subgroup of patients that this is going to be relevant in terms of improving the cardiac output and clinical outcomes. Let's go back to the clinical case. The fellow who assessed the patient came up and said this patient is unnecessarily pacing the ventricle, and that is the reason for the worsening heart failure. He changed the AV delay, and this patient had an intrinsic AV delay which was about a little over 200 millisecond and a narrow QRS, and we thought this patient will do well. Lo and behold, this patient did not improve despite optimal medical therapy, and this is the mitral valve filling pattern. If you look at the mitral valve filling pattern, E, A wave, and a diastolic mitral regurgitation due to a prolonged AV delay. Now, in this patient, it is the heart failure is partly driven not by ventricular dysynchrony, but by AV dysynchrony. So how do you optimize the AV dysynchrony is just shorten the AV delay. But if you shorten the AV delay by V pacing, you are going to worsen the ventricular dysynchrony. So there is an unusual reason for doing a CRT in this patient. You shorten the AV delay so that you optimize the AV delay. But to prevent a VV delay or a VV dysynchrony, you put a lead in the left ventricle, and this patient has done well, close to a year on follow-up. Diastolic MR, just a minute, I'll be winding up. Diastolic MR completely disappeared, and this patient was doing well. So, ladies and gentlemen, there are several other reasons more than just dysynchrony alone why the patient may not respond. It's not just putting the lead alone, you need to follow up these patients. So, CRT in conclusion is useful in patients with heart failure due to poor LV function and a wide QRS of LBBB morphology on ECG. It's not very useful in patients with systolic heart failure and narrow QRS. There is a potential for harm. However, for other patients with non-LBBB morphology, you need additional tools and look at other areas to risk stratify these patients before you opt on CRT or CRTD these patients. Please ensure that the LV lead is implanted at the latest site of ventricular activation and ensure there is maximal CRT delivery to ensure that your patient is doing well. Thank you very much for the patient listening.
Thank you, Narasimhan, for giving us very clear presentation. Particularly, the LBBB we know conventionally, but the non-LBBB and the RBBB what you touched upon. Now I would like to invite Dr. Balakrishnan, who is going to talk on left ventricular assist device and heart transplant. Dr. Bala.
Thank you very much. Right at the beginning, we need to define the criticality of illness in heart failure from the context of transplantation and left ventricular assist device. This for the postgraduates in the audience. NYHA class 1 to 4, which we've been using for a long time. Class 4 is too broad a category to be of much use in heart failure dealing with transplantable patients. So this classification of Intermax was introduced about 10 years ago. The difference between this and NYHA basically is that Intermax lower the number, more critically ill they are as compared to NYHA, where higher the number, more ill they are. Intermax 1 being critical cardiogenic shock. And why is it relevant? Like this study from Spain, where patients could be transplanted at will because of their organ availability. And even the study from the initial HeartMate 2 trial shows that lower the Intermax score, higher is the mortality. So it gives you a nice platform for comparing outcomes. And the current indications for transplant in our setup are end-stage heart failure, unresponsive to any kind of medical therapy, including a large percentage of patients who have had attempted CRT device. Where they are able to walk, we do a VO2 max. If it's less than 10, it's a clear-cut indication. Repeated hospital admissions. These criteria can be a little different in patients with restrictive cardiomyopathy. Coming to the current realities of heart failure patients seen in our practice, majority are very sick, Intermax 1, 2, or 3. Most have subsystem dysfunction. A lot of them have had a CRT device in place as recently as a few weeks, calling into question the indications for it in the first place. Creatinine more than 2 is the norm rather than the exception. Several patients are on dialysis. Unfortunately, because of the cost, the long-term valves like HeartMate 2 and HVAD are essentially used as a destination therapy in this country and not very useful as a bridge to transplantation. The organ donor situation in some states is quite reasonable, especially in our state, despite which there is a suboptimal utilization because of an affordable wire as a bridge to transplant and lack of good options for long distance transport of organs, and the average waiting time is less than 3 months. So when we first started our transplant program, we had a lot of challenges to overcome, and the first was a waiting list mortality, which continues to be around 30 to 35%. This is a historic slide I like to show. This is a child who had a sending repair in 1986 and came with severe biventricular failure. And I did this operation, I remember the date because this was December 31st, 1999, and everyone was predicting the end of the computer world. She underwent the transplant, did very well, the heart was beating very well, as you can see here. But she didn't survive very long because of the end organ dysfunction. So clearly, she needed some kind of mechanical support before she reached this place. The commonest bridge that we use is a humble bottle. It's a disposable Baxter product of milrinone. This saves a lot of lives, keeps them stable while they are awaiting a donor organ. In a select group of patients where milrinone alone doesn't work, we use intra-aortic balloon pump. Balloon pumps historically have been thought to be only useful in ischemic situations, but now there's a lot of evidence, including this from Heart Failure Jack, where in unresponsive patients to medical treatment with milrinone, balloon pump can make them pass urine. Despite this, there's a category of patients who become sick or have a cardiac arrest. So we started using extracorporeal membrane oxygenation at the bedside to resuscitate these from profound cardiogenic shock. And our first experience with this 34-year-old young woman from Delhi who was airlifted, became very sick, had a cardiac arrest, was resuscitated with percutaneous ECMO, and after a wait of 8 days, we could get a donor organ. She underwent a successful transplant, and 4 years later, she has a VO2 max of 42, and she could ski in Gulmarg and climb Vaishnav Devi. So if you're able to get them resuscitated and supported and get a good donor organ, use of a mechanical support is not a risk factor for death. Unfortunately, ECMO doesn't work very long. The complication rate increases after about 10 days to 2 weeks. So we had to devise another strategy. So we now currently use Centrimag pump. These are not very expensive. They cost around 4 lakhs per pump. So it's not 60 lakhs like a HeartMate 2. And these are not very difficult to implant, as I can show here. And they support the ventricle very well for up to a month, FDA approved, but you can push it for several months if needed. And we almost always use a Gore-Tex membrane because we have to come back to change the heart in any case, and extubate these patients as soon as possible and mobilize them. So it's a huge advantage as compared to ECMO or even intra-aortic balloon pump. These patients can walk around in the hospital. They can't be discharged from the hospital, but they can certainly be mobilized into the ward. And then there's no hurry to do a transplant. We wait till all the end organs have recovered. They're no longer jaundiced, they're making urine. Their coagulation profile is normal, they're awake. And then when you get a suitable organ, they undergo a transplant and they do very well. The youngest we have done is this 4-year-old boy who had a Centrimag insertion. And as you can see, they all get extubated on the pump. The other challenge was if you really follow textbook criteria, you would end up doing very few transplants in this country because by the time they come to us, they're very sick. So suboptimal donor is a huge problem, especially because you don't have an affordable VAD. Sometimes you get an organ, whichever is available to use. This was a patient with a high pulmonary vascular resistance with 3.7 Wood units, a TPG of 23. He couldn't afford a VAD. So we got an 18-year-old donor, and the right ventricle clearly is struggling, as you can see. So he was supported with a mechanical pump on ECMO for 22 days, by which time the ventricle recovered. So this is an example that a high PVR itself doesn't kill. What you need is to support the ventricle of the new heart till the heart gets adapted and gets some hypertrophy. Again, we extubate these patients as soon as they are able to be next day, and so this continues while the heart is getting adapted to the new afterload. This again is a typical example of an inadequate donor, 8-year-old girl, very difficult to get pediatric donors. She again had a profound circulatory arrest, a collapse. She was resuscitated with ECMO. 4 days later, we got a pediatric donor heart. Normally, we wouldn't accept such a heart with poor contractility. But by and large, in young donors, it's stress cardiomyopathy, and the heart would recover if you support it. At the end of the transplant, the heart was not doing much, so she was continued on ECMO, and after 4 days, she recovered completely. So we have a strategy for high PVR, unless it's very high, over 5 or 6. We use a lot of preoperative vasodilatation, nitric oxide. Sometimes we use temporary right ventricle support with or without ECMO. And especially if the recipient is not very heavy, using an overweight donor, especially a smoker, sometimes works. This is a 2-year-old child who with restrictive cardiomyopathy who underwent a transplant. Again, because of high PVR, the right ventricle is struggling, as you can see, it's not even in the screen. And after support of 12 days on an ECMO, she recovered, and at the end of 6 weeks, is normal. The other problem we had to overcome was end organ dysfunction, especially creatinine, because combined heart and kidney transplant in India is not easy because of the number of kidney donors exceeds 1,000. So we have modified our immunosuppression protocols to overcome those problems. The other problem we had to overcome was biopsies. If you look at American literature, 14 protocol biopsies are mandated every year. Each biopsy in our hospital costs 85,000 rupees. Patients come from all over the country, and clearly it's not something that we can do. So we do 2 biopsies, one at the end of the month and one at the end of 1 year, and our outcomes have not been any different from published literature. And we also needed to modify our immunosuppression protocol as compared to the Western literature, because the infection seems to be a much higher problem in India than rejection. The other huge challenge is transporting organs. You can get an organ in another city, but to transport them in the middle of the night is not easy. An even bigger problem is to transport patients. When you have a patient who is sick on a balloon pump, the typical air ambulance in India are these planes which are used for election campaigning by politicians. They often don't have a PowerPoint. Intra-aortic balloon pumps don't work very well. In fact, there is the drop of 20%. Intra-aortic balloon pump volume increased by 20%, and several of them don't even have a PowerPoint. So these are huge lacunae which need to be overcome. I'll come to the results at the end. Because I've been asked to speak about both transplants and LVADs. Long-term VADs in heart failure historically started off with pulsatile pumps, which are no longer very much used. This is a slide from our own practice from 2001, where we used to use this German pump. You can see the huge drive unit which needs to be lugged around. And this patient underwent a successful transplant after 8 weeks of support. But now we have more elegant continuous flow pumps. The 2 pumps which are available in the market, one is the axial pump on the left called HeartMate 2. They have a newer version now, and the other is a smaller pump which is centrifugal in nature called HeartWare. We need to understand the basic physiology of how continuous flow pumps differ from the normal heart. Interestingly, the first publication of Frank Starling curve was over 100 years ago, 1914 Journal of Physiology. And that really nothing but preload sensitivity of the heart. So the normal heart is 10 times more preload than afterload sensitive. And the afterload sensitivity is 3 times greater for VADs. Now, when somebody mentions this, it's not easy for you to understand what exactly it means in real practice. Again, these engineering graphs are very complex. So what I did was I redrew this. So you have a filling pressure on the x-axis and the flow on the y-axis. What it really means is for a normal heart, which is blue in color, if the CVP or LA pressure is low, the stroke volume is low, and as you increase the CVP or stroke filling pressure, the stroke volume, and so the cardiac output increases. Unfortunately, the pumps that we have designed are not exactly opposite. So even if the filling pressure is low, they cannot automatically sense it and decrease their flow rate. As a consequence, you have this. Suction events are a big problem in continuous flow pumps. The moment you have inadequate LV filling, and this could be because of hypovolemia, blood loss, hypermery vascular resistance, or poor right ventricular function, the pump sucks in onto the ventricle and causes fatal arrhythmias. A lot of algorithms are written for these LVADs to overcome this problem. Afterload sensitivity is an even bigger problem. The normal heart, the cardiac output doesn't change very much, whether the blood pressure is 110, 140, or even 100. Whereas continuous flow pumps, centrifugal more than axial, they're so afterload dependent that if the blood pressure increases to 90, the flow drops significantly. And if the blood pressure comes to say 60 or 55, the flows are 6 or 7 liters. Now this poses a huge therapeutic challenge in the intensive care, because if you want to increase the flow rate, you have to lower the blood pressure. But these are patients who had injury to the kidneys from long-standing hypertension. So at a blood pressure, mean pressure of 60 or 60, they may not be making much urine. So sometimes it can be a huge challenge managing the pressure and the flow in the intensive care situation. It's important to remember this. Our first experience with the destination LVAD was 4 years ago on this 58-year-old businessman. I'll skip the operative picture. And he started walking for the first time in 7 months. And 3 months later, it completely recovered. And in 1 year, he became a grandfather. In 2 years, he's back to being what he was, obese and fat. So these pumps give you an excellent quality of life in terms of recovery from heart failure. The newer generation pumps are small. They're about 150 grams in weight, the size of a golf ball. They can be completely implanted within the pericardial cavity and no need for a pocket. Increasingly, we do it through a small thoracotomy using minimally invasive surgery often without using the heart lung machine. There are still unsolved problems with VADs though. The biggest problem is an infection because they all need a power source which is born outside the body. So there's a drive line which comes out and the infection rate increases with time. And by the time they're 3 or 4 years down the line, there's almost 60-70% incidence of at some episodes of infection, and it can be a very significant problem. 30% of these patients develop a GI bleed because of damage to the von Willebrand factor because of the pump rotation. Strokes continue to be a problem more with hardware than HeartMate 2, but the incidence varies from...
Sir, I am sorry to interrupt you, but last 2 minutes.
Okay, I'm done. The VAD is still work in progress, though it's substantially improved the prognosis of heart failure patients. Measuring blood pressure is often not easy because it's a continuous flow pump, but the quality of life is excellent. Finally, comparing transplants and VADs, transplant is the gold standard. They can be done even if both the pumps, the right and the left ventricle, is poor, and there's no need for a battery or a charger, but they need a low PVR. In comparison, VADs can be done even if the PVR is high. They need only warfarin, but they need a good right ventricle. The reason they need a good right ventricle is the two ventricles are in series, so if the left ventricular function is improved with a VAD, or the output is improved with a VAD, the right ventricle needs to cope with it. And if it's not, the right ventricle would fail. So we use echocardiography to measure several indices are used for RV function assessment. And these are rough guidelines clinically. If you see a patient with heart failure, you look at the right ventricle function and the PVR, and depending on that, you choose for a VAD or a transplant. And finally, with the availability of both, increasingly we have referred patients who are sick and frail as well. So you have to distinguish the heart failure component from the frailty, because putting a new motor in a rickety old car running out of gas may not be necessarily a wise thing to do. Hippocrates got this a long time ago when he said you need to know what kind of a person has the disease than the other way. And it's often a dilemma. Now increasingly more scientific methods of identifying frailty are around, and a lot more literature has come up. And I'm sorry, I'll skip all this. So finally, this is the most important slide. We have had a total of 178 patients that we've treated. 24 had an LVAD, 114 had a transplant. 7 of those transplants was the early part of the experience, and 107 was the recent one. The 1-year survival is close to 88%, but the event-free survival drops for an LVAD after 1 year because the complications I mentioned, but the quality of life is excellent.
I regret you will stop. Yeah.
I'm done, yeah, sure.
Do we have time, because it is 12? Yeah.
I think we have time of 5 minutes.
I'm sorry.
What? 5 minutes for discussion. I'm sure you will agree that we had a wonderful talk on the assist device as well as on heart transplantation, because heart transplant today is a great attraction not only to the medical professional but to the public at large, and on the above the media talking about the green corridors and getting the rare transplant. I think we'll have a time of about 10 minutes and we can have some questions from the audience. Please identify yourself and then ask the question.
Give a mic there, please, and one person at a time.
Dr. Soneji.
Hello.
Senani first.
Just put it on here.
Senani from Mumbai. I have a question for Professor Michel, who spoke on the targeting the heart rate with beta blockers and evaporating. See, in my experience, if you can target it only with beta blockers, when do you decide to give evaporating? Do you give it when you find left ventricular ejection fraction is low, or what? Because in some cases you can manage only with beta blockers.
So I would simply follow the trial and what has been done in the trial, and this is that patients had to be on a maximal therapy, and this includes a beta blocker. So you start with a beta blocker, which is in the guideline in class 1A recommendation, and when despite a heart rate of above 70 in sinus rhythm, the patient stays symptomatic, then you reduce heart rate to 50 to 60. So the first step is a beta blocker, and then ivabradine is added on the beta blocker. If a beta blocker is not tolerated, then you can start with an ACE inhibitor. with
So it's
ivabradine.
not necessary to start in everybody. If you can achieve with beta blockers, you can be happy, no? Right?
Right, but heart rate should be reduced on beta blockers
Below 70.
below 70.
I am Dr. Soneji. Question for Uday Jadhav. Having given your total iron therapy, when do you repeat your ferritin levels and how frequently can you give?
You'll have to go by correction of the anemia and the serum ferritin, transfer in saturation. If you are giving 500 milligram as a IV bolus dose, then you can repeat it after 1 week, after 7 days. And it would be good to then assess how the serum iron content is and then take
I
it
normally
forward.
give 1 gram to 1.5 gram.
You can do that also.
And
There is a trial
I'm
already
pretty-
talking
yeah,
of
I'm
1000
pretty happy with that,
milligrams.
but when do I reassess them?
Reassess them. It goes by clinical after you give the initial doses. And if you look at most of the clinical trial, it's 2 weeks, 2 weeks, 4 weeks, 8 weeks. Yeah. So Michael, I had a, can I ask you a question on ivabradine? There was some concern about new onset of atrial fibrillation. So is there really a concern, and if so, is there a mechanism how ivabradine can, if at all, cause atrial fibrillation?
That is very tricky. I mean, this is a real effect. The effect is small. There was an excess of 2 absolute % new onset atrial fibrillation in SHIFT, in Beautiful, and in Signify, in all the trials. And the mechanism is not quite clear. There is also, we did an analysis from the on-target trial, completely different in sinus rhythm, where the increase also in patients who have a naturally low heart rate of about 55 and lower, the incidence of atrial fibrillation is increasing. So with the development of extreme bradycardia, you select patients who have a conduction disease in a wider sense, and they are more prone to develop atrial fibrillation. And the other thing is that in low, when you have chronotropic incompetence and you exercise, there is an increase in filling pressure and a further dilatation of the atrium, because the atrium needs to contribute more to ventricular filling. So this is discussed as a mechanism of atrial fibrillation in long-term ski runners from Scandinavia, in sportive people where there is also an increase of atrial fibrillation. So there are 2 potential mechanisms, but low heart rate when it comes to below 60 intrinsically is associated to atrial fibrillation.
For injectable iron therapy, can we use any other conventional preparation besides the carboxymaltose iron?
You can use intravenous sucrose also, which has been time tested.
Same. If
I think ferroxycarboxymaltose gives you better clinical
Better.
advantages because of the trial data.
Thank you.
Any other questions?
I have one question. What is the role of ivabradine in today's time in pure diastolic heart failure?
This is top secret. There is a trial, the EDIFY study, which will be presented hopefully at the American Heart or later, where there is an echo sub-study and a sub-study and a study on exercise tolerance. It's not an outcome study where ivabradine was investigated, but these results, it's the data are evaluated now. It's not finished, but there is a study with the hypothesis that prolonging diastole improves filling and improves cardiac output, but this is still ongoing.
Yeah, coming back to ivabradine again. Its effect on AV node and bundle branch, is it entirely free, or what is the clinical implication?
If a patient has pre-existing bundle branch block, then you can use it. There is one analysis in patients with left bundle branch block and without bundle branch block. We had 900 patients in SHIFT with a left bundle branch block, and the benefit is the same as in those patients with a small complex. Yeah. However, these patients should have a CRT, obviously. When SHIFT started, the number of devices were quite low, because we also discouraged to put a CRT or a pacemaker in, because we wanted to have the effect of true heart rate. So with pacing, there is interference with the effect of ivabradine.
And its effect on AV node?
The effect of AV node is negligible. It's not detectable. And on treatment, there is another analysis from SHIFT, no increased rate of severe conduction disturbances which could cause a safety signal. This was not the case in SHIFT.
Michael, one question to you. What about use of ivabradine in acute heart failure? Because 90 blood pressure is given as a relative contraindication.
Yeah,
because we cannot use many drugs during acute decompensated heart failure and BP say 90, 100, and there is a tachycardia. What is your...
For this, I have an opinion, but no data. The point is that there is no study in acute heart failure except a very small study on IV use on ivabradine showing safety, that hemodynamically nothing is happening, no drop in blood pressure, which is indeed an advantage. There are some case reports and small case series showing even in cardiogenic shock that when you reduce heart rate in those patients on dobutamine or who have catechols and have a high heart rate, that the chronotropic inotropic balance is improved. So therefore cardiac output is increased. I think this is a very urgent need to have a trial in this area, but this is not followed up by companies presently, unfortunately. I think there is a great chance, in particular in patients with cardiogenic shock, to be useful.
But in your routine practice with a BP of 80, tachycardia, you still use ivabradine or no?
I would use ivabradine. Nomically, there is a small increase in blood pressure by 2 millimeters in mercury in shift. We looked at that in patients who have a blood pressure of 80 to 90 in cardiogenic shock. 3 patients, there was no drop in blood pressure. Yeah? But this should not be a general recommendation because we do not have a trial.
Because 90 blood pressure is given a cutoff, not to use.
Yeah, sure. Yeah.
Okay, so we have the last question, please.
Dr. Balakrishnan,
Brief.
You said you do biopsies twice a year as opposed to America. So we have more problem of infection in our country for transplants, and the Westerners use more immune suppression. Your experience on using immune suppression protocols in our Indian subset of patients, especially with respect to tacrolimus, because I think tacrolimus seems to be the more toxic out of all the other drugs, and any role of cyclosporin in your experience or your distillative experience of immune suppression in our country, especially with regard to tacrolimus?
We figured out 3-4 years ago that like a lot of other drugs, the typical Indian patient with our build, they don't tolerate so much of steroids. So for a start, we very rapidly bring down our steroids to around 5 milligrams a day by the end of a week. And we maintain a tacro level of around 6 to 7. And we prefer tacrolimus to cyclosporin because the dosages are less and it's easy to control. And not doing biopsies every month has not had a significant negative outcome. In fact, we published our results in the International Journal of Heart Lung Transplant in April, where we found that the 1-year survival was identical to what are the published results, despite reducing the number of biopsies. And increasingly, we are using blood-based immunological surveillance, including cell-free DNA of donor origin and immunogenes. So I think worldwide, there's a trend towards going away from biopsies.
Okay, so thank you very much. Thank you all the speakers, Dr. Anil, Dr. Michael, Bala, and Narasimhan, and all the panelists. And we go ahead and have the second symposium on hypertension. Chairpersons for this, Dr. D.B. Pailajani, Dr. Anjanlal Datta, Dr. Amal Banerjee, Dr. R.C. Khokhani, sir, Dr. Eric Borges, Dr. Parvez Grant. And the first talk is by Professor Dr. Roberto Ferrari on do we need to change the current definition of resistant hypertension. I also announced that the Hall B has now started, the Interventional Cardiology Hall. So it starts now and will go through the day. So those who are interested in the interventional cardiology can anytime proceed to the Hall B. Thank you.
Good afternoon, friends. We have a very interesting symposium just now, and there's a burning issue of hypertension. There are so many issues which have been sort of sorted out, but still many of them need to be sorted out. And we have several topics under the heading of hypertension which we are going to discuss. And the first speaker is Dr. Roberto Ferrari. As you know, he has been the president of the European Society of Cardiology, and we request him to come and speak on, do we need to change the current definition of resistant hypertension? Dr. Ferrari, please. Pardon? I saw him in the faculty lounge. I didn't meet him there. Okay. My co-panelists said that we can go to the next one. The next one is no less known person than Roberto Ferrari, is Dr. C. Venkatram. Venkat? He's the man who has done a monumental work in the field of hypertension, and he is dear to all of us. We have interacted with him several times, and his topic is, do we underutilize ambulatory blood pressure monitoring? Ram?
Okay. Thank you very much, Dr. Pailajani and all the chairpersons. Greetings to all of you. You will notice from the program, I'm filling in for Dr. H.K. Chopra, who could not come. So this is something that I will try to say what he could have said. Let us see it. Some comments on ambulatory blood pressure monitoring. It's a technique that has been around for more than 30 years. But the gap between the technique and applicability has not changed. So much has been written about ABPM, and so many things have been developed, but the role of ABPM in routine management of hypertension remains as elusive as it was 30 years ago. Having said that, let us quickly review some of the aspects of ABPM that could be useful in clinical practice in evaluation and management of patients with hypertension. As all of you know, when you measure the blood pressure for 24 hours, the blood pressure fluctuates quite a bit, and you will notice that normal blood pressure does fluctuate even in normotensive individuals, but there is a decline during the sleep because of deactivation of the renin-angiotensin system and deactivation of sympathetic nervous system. People always ask, why does the blood pressure fall during sleep? Because you are disconnected from external stimuli that can participate in the pathogenesis of hypertension. So basically, you have no external input to activate the neural mechanisms that could elevate the blood pressure, and that is the reason why the blood pressure falls during night. And these are the normal values and how to classify people as having high blood pressure or optimal blood pressure by taking daytime, nighttime, 24 hours, and I'll go into this later on. The chronobiology of cardiovascular homeostasis is not limited to blood pressure. All of you are aware that there are a variety of cardiovascular syndromes that appear to occur more in the morning period than other time intervals a day. The precise mechanism is not clear, whether it is vasospasm or thrombosis, but nevertheless, for cardiovascular problems in patients with hypertension, the morning period appears to be somewhat susceptible. The other thing that has been brought to our notice, mainly from a couple of studies from Japan and from late Dr. Pickering, is that the morning rise in blood pressure or a surge in blood pressure is accompanied in a way that it could cause cerebrovascular accidents or acute myocardial infarction. So this is the time where there appears to be a tremendous susceptibility of the brain and heart to experience ischemia. Now, this is a study that was done by Dr. Cario and Pickering many years ago, looking at the data on people who have cerebrovascular accidents and correlated to people who have morning surge in blood pressure. You will notice those individuals who had so-called morning escape of high blood pressure had the high incidence of cerebrovascular accidents. And this is a very pivotal study that suggested that there is a coexisting relationship between the morning rise in blood pressure and acute cerebrovascular ischemic events. And all of you are familiar that for reasons I have mentioned, that the blood pressure should fall about 10% at night time, and if it doesn't, then the patients are susceptible to various cardiovascular complications. One of the things that has been known, one subset of patients who appear to have significant hypertension are patients with chronic kidney disease. All of you know that terrible types of hypertension are seen in patients who have chronic kidney disease. And it looks like in patients who have declining renal function, there is greater propensity for persistent nocturnal hypertension. So one category of patients where ABPM might be useful in clinical relevance is patients who have onset and progression of CKD, and very characteristic pattern of this is nocturnal hypertension. And these are the data that were summarized by Jan Stayson and co-workers from SISTIO trial, which is the second largest trial at that time for hypertension in the elderly in Europe. And they have mapped at the events on the vertical scale and the blood pressure, whether it is 24 hours, nighttime, daytime, or conventional office. You will notice in this very important study, the best correlation was with nighttime blood pressure and 24-hour blood pressure. So one can indirectly conclude that in elderly patients with hypertension, nocturnal increase or lack of fall in blood pressure might be an important predictor of cardiovascular events. Very, very important finding from SISTIO. And they have further analyzed in subsequent studies, very similar, looking at nighttime blood pressure, 24 hours, daytime or conventional. Conventional BP measurements were least sensitive compared to other hemodynamic parameters studied. This is a small study looking at the night to daytime ratio and the cardiovascular events. You will notice in patients who have no dipping or an increase in blood pressure, reverse dipping, there is increased incidence of cardiovascular events compared to those who have normal dipping. And of course, extreme dipping, I will not comment on it. Some people do feel that extreme dipping might be a harbinger of cardiovascular events also. This is a very nice study looking at when there is a nocturnal increase in blood pressure, lack of dipping, a rise in blood pressure. Whenever there is a rise in blood pressure during nighttime, there is increased incidence of cardiovascular events, including mortality. So when you look at 24-hour blood pressure monitoring, a paradoxical rise in blood pressure might be an important prognostic factor for cardiovascular disease as well as for cardiovascular mortality. Once again, this is a study in patients with congestive heart failure, which is not really a good model to study blood pressure because various counter-regulatory phenomenon are coming to force in patients with congestive heart failure. But nevertheless, patients who had a nocturnal systolic blood pressure less than 120 had a better survival from stroke compared to those who had a sleep blood pressure greater than 120. So one more parameter for ambulatory blood pressure monitoring. For cardiovascular profiling, patients who have chronic congestive heart failure, the nighttime blood pressure might be one of the adjunctive factors for cerebrovascular events. When it comes to therapy, it has been argued that the importance of 24-hour blood pressure monitoring is that some drugs, although they're discontinued for a day or two, they continue to have an antihypertensive effect. And this is a study that compared the previous generations of ARBs, telmisartan and valsartan. I know valsartan is not that much used in India for hypertension, but nevertheless, this suggests that when you miss a dose of valsartan, the blood pressure is reclaimed within 24 hours, in contradistinction to a longer acting ARB, where the sustained efficacy despite missing the dosage. Of course, you don't tell the patients to miss the dose, but missing the dose might have persistent antihypertensive effect in long acting drugs. So let me then quickly conclude in next few minutes that when you see a blood pressure that is around 125 or 80 in the proximity, it corresponds to a clinic blood pressure of 140 or 90 or less, which is actually very, very good. And I'll talk about later on how to interpret the SPRINT data, because the SPRINT trial results, the interpretation has been very, very confusing, and I'll talk about SPRINT data later on. So let me then quickly suggest that when you look at 24-hour blood pressure, not only you look at cyclical, average, daytime and nighttime, but the patients who are unable to suppress their blood pressure at nighttime, it only indicates they have persistent hypertension and they have significant cardiovascular problems. There is one more condition that has been associated with or accompanied with, that is obstructive sleep apnea. So far, I have described to you chronic kidney disease, congestive heart failure, and now obstructive sleep apnea. Obstructive sleep apnea patients have been shown to have persistent nocturnal hypertension. And studies have shown that with appropriate reoxygenation by CPAP, the nocturnal blood pressure goes down, and that could be an adjunctive therapy to reduce the cardiovascular events in patients who have obstructive sleep apnea. And let me show you a few examples, and then I will conclude, Mr. Chairman, ladies and gentlemen. This is a category that is clearly in various commentaries as an indication to get 24-hour blood pressure when you feel or when the patients feel that they have white coat hypertension. I can't tell who has white coat hypertension because they all look the same to me. But having said that, in patients who have so-called office-associated or clinic-associated blood pressure, if you hook them to 24-hour blood pressure monitoring, they actually have normal blood pressure patterns. So this is one more indication. Isolated systolic hypertension, which is probably the principal cause of cerebrovascular disease all over the world, can also be detected very, very nicely by 24-hour blood pressure monitoring, very wide pulse pressure in patients who have significant isolated systolic hypertension, seen very, very nicely in 24-hour ambulatory blood pressure monitoring. In patients who have hypertension, and if you give what you feel is appropriate therapy, some of them actually have a reduction in blood pressure at nighttime. So a patient with hypertension, if they lower the blood pressure at nighttime, that appears to be beneficial, although one cannot be too conclusive. Now look at this patient who has chronic hypertension, but the blood pressure persists throughout day and night, and such a patient is a great risk for heart disease, cerebrovascular disease, CKD, and progression of CKD to end-stage renal disease. Autonomic dysfunction that sometimes cardiologists are asked to see, very, very frustrating. There's no good treatment. You can try anything you want. The treatment is not appropriate, but autonomic dysfunction can also be further defined and profiled by 24-hour blood pressure monitoring. Let me show you a couple of patients that I have seen.
We've got 2 minutes left.
Okay. Let me show you a few examples. This is a patient, 19-year-old college student who was going to college in US. He came to visit his parents in Hyderabad, and he was told in the college in US that he has high blood pressure. Obviously, patients were shocked, parents were shocked, so they brought him to me, and I did a 24-hour blood pressure monitoring last week, and you will notice his 24-hour blood pressure was normal, daytime blood pressure was normal, nighttime blood pressure nice dipping. There was not a single reading that was high in this 19-year-old. My advice to him was study well and just enjoy life. Forget about this blood pressure that was taken in the office. This is one patient whom I saw with obstructive sleep apnea recently, persistent hypertension, and then there is no nocturnal fall in blood pressure, and his partner told me that he's constantly snoring at night. So one more example where 24-hour blood pressure monitoring might be helpful. I will not go into this very complicated algorithm, but in patients in whom the self-monitoring of blood pressure is normal, probably you don't have to do much, but if the blood pressure is slightly high, then you, based upon your clinical evaluation, you can do the clinical evaluation plus minus ambulatory blood pressure monitoring. So, Mr. Chairman, ladies and gentlemen, in conclusion, the paradox of 24-hour ABPM remains. There is a big gulf between the physiology and practical application because these are not that easy to do. This is not like taking thermometer or taking the body weight. So it has to become easy and friendly in the future. These are some of the indications: reverse hypertension, target organ damage, but office blood pressure is normal, paroxysms of blood pressure, resistant hypertension, CKD, obstructive sleep apnea. Pregnancy might be another indication, particularly in the absence of full-blown preeclampsia like proteinuria. The question that has always been asked, is hypertension by itself an indication to get 24 ABPM? Should you treat hypertension only on the basis of 24 ABPM? So people have always asked me, does the diabetologist treat diabetes without glycated hemoglobin? Does the oncologist treat cancer without histological diagnosis? Should a clinician treat hypertension without 24 ABPM? And that remains to be seen in the future, hopefully with convenient measurement of 24 ABPM. Dr. Pahalajani, chairpersons, ladies and gentlemen, I'll conclude. Thank you very much.
Thank you, Venkat, for your excellent deliberation emphasizing the importance of ABPM. Now I invite Professor Roberto Ferreri to speak on, do you need to change the current definition of resistant hypertension? All of us know that he is the past president of European Society of Cardiology and is also a good friend of India. Roberto, please.
Indeed, I'm a great friend of India, and any opportunity to come to your country is extremely welcome from myself. Now, resistant hypertension. Let's define it. It is a failure. How does this work? Okay. It is a failure to achieve the goal of blood pressure when the patient adheres to maximum tolerated dose of at least 3 antihypertensive drugs, including a diuretic. And this definition does not really apply to the recently diagnosed patients. I'd like you to consider this wording: adheres, maximum tolerated, 3 antihypertensive drugs, including a diuretic, because this is the key of the definition. And it's a key because often we fuse the wording resistant with the uncontrolled or with pseudo-resistance hypertension. And patients with uncontrolled hypertension are those patients in which the blood pressure is not controlled because of inadequate treatment, because of poor tolerance, because of undetected secondary hypertension, and very rarely because of a true resistance hypertension. And the pseudo-resistance is a lack of blood pressure control in patients in which should be controlled, because they are not real resistance hypertensive. And the reason for that are many, because of suboptimal blood pressure measurement, because of poor adherence, because of the white coat effect, because of inappropriate combinations, or because of clinical inertia. This is not working very well. Do you have another one? And let's look at, oh, sorry. Yeah. Okay. The suboptimal measurement of blood pressure is, to me, a very common phenomenon. But we need to be honest to admit that. And honestly, you are really excellent expert. Do you really do all of this? Do you allow the patients to sit quietly for some time in your office, maybe 5 and 10 minutes? Do you take 3 different measuring, 5 minutes each from other? Do you use the right cuff adequate to the arm? Do we keep the arm at the heart level? Very rarely we do that, if we are honest. And this is because our offices is extremely busy, and also because in Europe, or I should say in Italy at least, the average time for a cardiologic visit, which includes also an ECG and a quick look at the echo, is between 15 and 20 minutes. So it is very difficult to be really sure of what we are looking at. The white coat effect has already been touched by the previous speakers. It is rather common, and almost 25 of the patients suffer for it. The solution, we already heard, is to do the home monitoring. Poor adherence to therapy. This is also very common. Up to 40% of the patients newly diagnosed. And quite interestingly, about 50% of your patients will discontinue treatment within 1 year. There are possible solutions to avoid side drugs which can produce side effects, to avoid complicated dosing schedules, to use pill boxes, and more important than anything else, communicate as much as possible. And also, whenever possible, try to use combination therapy. Communication. There are a lot of communication barriers. And again, we have to be honest, beginning from us. I'm not referring to you that you are here and so on, but how many doctors remain uninformed of the very quick advance in medicine? How many of them are not convinced of the use of the guidelines, of use new drugs? How many they forgot something that have learned during meeting like this one? They may be just influenced by marketing. They may be unwilling, and I know many, to accept what they consider compulsory recommendation. A lot of barriers. But there are also barriers from the patients. Often they are not convinced from the benefit of what you are telling them. They often are inadequately informed. They might fear of adverse reaction. They might have cost problem, particularly, I guess, in this country. Or they might have other treatment priorities. It is astonishing that 40 to 80% of the information provided to the patients is immediately forgotten. Half of the information recalled are incorrect. There are studies looking at what the patient is telling to his relative about the relationship with the doctor. And let's be honest again, physicians and patients elaborate their personal mind lines. They get what they want, in other words. But there are also communication barriers from the industry. They try to communicate more the high prices new drugs. They have often consumer advertising. They might be very effective in marketing inferior drugs, and we know that this is really happening. They may have direct or indirect funding with physicians, organizations, patients groups, and so on. Another possibility is to use combination therapy. This is also suggested by the guidelines, particularly when the blood pressure is markedly elevated or when the patient is at very high risk, and the guidelines are leaving you and us to choose the combination that you prefer. The only one that you should be careful is to combine an ARB with an ACE inhibitor, because it can produce more strokes and kidney problems. The result of, and then we have the clinical inertia. Not always physicians treat hypertension properly. We have to admit that. And it's quite strange that this is particularly true from our colleagues in the US. There is often overestimation of the care, sometimes wrong, already provided, and not always there is the effort to adhere to the guidelines. The result of this is, at least in Europe, that blood pressure in patients who know that they have it and who know that they are at risk for coronary artery disease still is a problem. This is a registry of the European Society of Cardiology, the Eurospire registry, which is very good because it is conducted through the years, always using the same methodology, so you can really compare the data. And if you can see through the years, 54% of patients still are hypertensive, and they know that they're hypertensive. And in 10 years, we have been really able to reduce them to only 45%, not real a big success. And this is because there was an increase of the drug use for hypertension. Is this real resistance hypertension when you have taken away all these confounding factors exist and is a problem? Well, we do not know because the data are scanty. It seems to be present in 5% in the general medical practice. It goes up to even 50% in the practice of cardiologists and neurologists. There are many factors that may contribute to that, many drugs, from non-steroidal anti-inflammatory, from sympathomimetic, the use of cocaine, amphetamine, liquids, and alcohol in great amount. This is particularly important. We need to take care of that, about the salt intake, which should be limited to 2, maximum 3 grams per day. The renal parenchymal disease are a possible cause of resistant hypertension. Also obesity, male, being Afro-American, and aging. Other factors that may contribute, and that has been touched by the previous speakers, the obstructive sleep apnea and all the form of secondary hypertension. The treatment. A diuretic is a must, and you can use the diuretic that you want, but today we know that the spironolactone is probably the best of all of it, and that is because of the pathway study which tested the hypothesis that further diuretic therapy with the spironolactone in patients with a real resistance hypertension already treated with the free drugs plus one diuretic will be more effective to lower blood pressure than alternative treatment. And this is an interesting study. As you can see, not many patients, 314 patients with resistance hypertension, have been randomized to the free drugs treatment that they were having, including placebo, to spironolactone. And each of this cycle was for 12 weeks. There was a forced titration and no washout period, and the endpoint was home systolic blood pressure measured at 6 and 12 weeks, and these are the results. Adding spironolactone to the free drugs plus placebo, or to bisoprolol and azoxystrobin, or to the free drugs and bisoprolol and azoxystrobin, always resulted in a very clear and statistical significant benefit. The side effects were minimal, much to our surprise, and as you can see, the indication is quite important. The results in favor of spironolactone was unequivocal, is the most effective treatment for resistance hypertension. These results should influence treatment with the guidelines, and perhaps we should modify the definition of resistance hypertension and include the wording spironolactone in it. In London, during the IIFC, there was also other important data suggesting that diuretics can be very important for treatment of hypertension, and this was the pathway 2 studies, starting from the fact that the use of thiazide diuretics for hypertension is complicated by glucose intolerance and hypokalemia, while the potassium-sparing diuretics such as amiloride have the perception that they do not reduce enough blood pressure. So the idea was to combine these two compounds, and the study was done with one arm with only amiloride plus hydrothiazide and hydrothiazide alone. And as you can see, the classical results with the hydrochlorothiazide, there was an increase of blood glucose reduction.
Roberto, we have only 1 minute more.
Okay, I will go very quickly. When you combine these two drugs, you can reduce nicely blood pressure and no effect on potassium. Other drugs that can be used are the ones that you know. I will skip this. This is just to say that I like particularly the calcium blockers and ACE inhibitors. The ARNI, the ARB and the priloside inhibitors, we heard from Professor Baum about this, is quite a promising possibility. There is a clear reduction of systolic and diastolic blood pressure, either brachial or central. So that could be for the future. The transcatheter renal denervation was very successful at the beginning when it was not conducted in control studies, but when conducted with controls, there was no real effect. And the last, this is a small studies done in Norway. What they did, they took patients with resistance hypertension, taken into the hospital, and they monitored the taking of the drugs in the blood. And as you can see, pharmacotherapy is really superior to the renal denervation. Conclusion: resistance hypertension, when and if really exists, is a major issue, because we need to do something for that. The medical community has to be honest and cautious before labeling a patient with resistance hypertension to therapy. Equally, the medical community needs time and instruments to perform the art of medicine, and that is not always the case. Thank you very much.
Thank you, Dr. Roberto. You've done a fantastic presentation regarding resistant hypertension, the definition and the treatment. Very well done and superb. Thank you very much. We'll call the next speaker, Uday Jadhav. And Dr. Jadhav will tell us whether we should use dual therapy, triple therapy combinations. Thank you, Dr. Jadhav. Go ahead.
Right. Thank you, sir. Thank you, Chairman, sir. So, well, combination therapy in hypertension, what is this the way to go forward now? Combination therapy is the way blood pressure has to be treated. There is nothing new about it. It has been there in the guidelines, and no matter what drug you use. Look at the ESC guideline, they have been absolutely straightforward about it. And we refer back to a paper by Peter Sevier and Franz Mazzoli about 5 years back in the European Heart Journal, which said 60% of all blood pressure patients will require a combination therapy, 2 drugs at least. And it goes by the guidelines too. If you look at the diabetic patients, close to 75 to 80% will require a dual combination therapy, at times a triple combination therapy, because you are working at different pharmacological mechanisms. So you look at the mechanisms and then say, let me combine this and that, and that should be the way forward. So there's nothing new I am telling you. This is how we practice medicine. This is how the world practice medicines. It's there in the guideline. The next 2-3 slides you have seen n number of times, but just to make it straightforward, I'm putting it there. Is there evidence? Yes. Trinity study already showed that when you combine a ARB with CCB and a diuretic, and a large study, 3-month study, already showed that it worked very, very well. There is absolutely no doubt on this. This is the combination therapy of the triple drug, olmesartan, amlodipine, and a diuretic, and you can see the drop in systolic diastolic blood pressure, very, very effective. We have plenty of studies, both from this country and from across the globe, which has shown both dual and triple combination therapy, which work very well. So that's it. Now let me put few new thoughts, or which drugs probably you can use. You also have those guidelines. So I'll just put in a few thoughts which may be relevant to the whole discussion. One is, how do you choose between a RAS inhibitor with calcium channel blocker or a diuretic? It goes patient by patient, but here is a meta-analysis of 20,000 patients in the recent times, published 2-3 months back, and it showed that for all endpoints, the cardiovascular composite endpoints, mortality, non-fatal MI, non-fatal stroke, the combination of a ARB with a CCB always scored over a combination of ARB plus diuretic. We have a data previous to this, but I think this is something which we need to keep in mind. Also, you have a lower estimated GFR when you use this combination. The adverse effects are as good as when you combine with other drugs, and significantly lower incidence of serious adverse side effects. We might want to keep this in mind because diuretics do have a little problem in our country. Our patients don't tolerate a very higher dose of diuretics, so probably one feeling is that CCB may work well. The other thing is, when you choose amongst these drugs, let's say the RAS inhibitors, they are superior in some way, as Professor Dr. Venkatram also showed and mentioned in the ambulatory blood pressure slides. One is the morning surge of blood pressure. So this is one of the papers we had in New York recently at the ASH meeting, And I still feel if you look at the sleep trough surge, where you take the 4 readings 2 hours after the patient wakes up, and you take the mean of 3 readings around the lowest on the ambulatory blood pressure. And if you compare this data, if you take one of these and we took all the 3 parameters and we compared olmesartan and telmisartan, there's no difference in the p-value. All of them worked very, very well. The morning blood pressure wake-up BP was 116 with olmesartan, 119 with telmisartan, no significant difference. The ARBs do not, they protect against the morning surge of blood pressure, and that's the beauty of the RAS inhibition. Therefore, they must go in all dual or triple combination therapy because it will score over the other group of drugs. The SPRINT trial, I am not addressing the SPRINT trial, but just putting 1 or 2 thoughts. Chlorthalidone was one of the diuretic which was encouraged. Amlodipine was the CCB which was encouraged. And ARB when needed to be used was azilsartan. If you look at the last line, the number of drugs required to effectively control the blood pressure was 2.8 in the intensive arm. So you require a triple combination if you wanted to have the blood pressure at that level, or 2 drugs in the standard arm. But this tells you already the story that all patients, even when you look at the SPRINT trial, there's a large number of patients who will require this combination of therapy. Small thought on azilsartan. This is a meta-analysis which we sort of presented at the ASH meeting, that azilsartan is a good molecule and it will certainly help in all those patients which we are not able to control with other ARBs. That's probably where we will place it. And when you combine it with chlorthalidone, it will give you a little superior advantage as versus when you combine it with thiazide. So this is 35 versus 29 millimeters when you combine the two, and that is superior to the older ARBs. Here the comparison was with candesartan mainly because the trials use candesartan. If you look at the SPRINT study, and this data I don't think is published as yet, this is the ambulatory blood pressure data. In the SPRINT, there are not many patients. These were close to about 400 patients. And you can see both in the intensive and the standard treatment. The intensive treatment with 3 drugs lowered the blood pressure much better than when you use 2 drugs for the standard therapy. A 10 millimeter difference in nighttime systolic blood pressure, a 12 millimeter in daytime systolic blood pressure. So this is something that we need to understand, that there is a utility of using these 3 drugs. Is there a concern? This just 2 slides were for the elderly group in this SPRINT, which was published in JAMA. In case we start using 3 drugs more commonly as a combination pill, one of the disadvantages would be the side effects. The elderly patient in this SPRINT did not show a statistically significant difference in terms of adverse effects, but they were more. For example, hypotension, syncope, electrolyte abnormalities, acute kidney injuries, injurious falls. Not statistically significant, but yet there is a little increase in incidence. So when we talk about combination therapy, this is one concern we might want to have in day-to-day practice, that we will see more patients with electrolyte imbalance, we'll see more patients with AKI, we'll see more patients with near fainting episodes. In cardiac patients, here is a subset of cardiac patients taken up in the VALUE trial, and they looked at what happens when you aggressively lower the blood pressure in patients with hypertension and coronary artery disease. It looked like, though it is safe and the J curve possibly does not exist, but you may have, as shown in the next graph, a little heightened events when you drop it down to less than 130/80, and this was the conclusion, that although it looks safe trying to get down the diastolic blood pressure to less than 60, but then it cannot be excluded that they are slightly less beneficial than you have values above these cutoffs. And therefore, in the cardiac practice, maybe patient with hypertension with coronary artery disease, you might want to still not lower the blood pressure too low, get it down to below 70 because there could be a concern. And the last few lines are on diuretics. This is one of the good analysis. There is a tendency to believe that cardioprotective drugs, RAS inhibitors and calcium channel blockers and beta blockers and diuretics by themselves do not make a difference. That's very untrue. Here is the risk of CV events and strokes and coronary artery disease, and you can see when you use chlorthalidone and indapamide as superior drugs to thiazides, very certainly over a period of time the cardiovascular events went down. For example, if you look at 4 years data, 14% reduction in the cardiovascular events, 40% reduction in the heart failure events. So there is a place for diuretic for sure, not just for blood pressure control, for cardiac protection too. The question is, when you use this, will we have more side effects? And that's a matter of debate, because if you look at trials, and when I listen to very learned people talking to us, they say, which patients get hyponatremia? It's the elderly women above the age of 60 years. I don't agree with this. If you go back to your clinical practice, you will see a lot of patients, irrespective of the diuretic you use, getting significant hyponatremia. We get patients into the intensive care units too, who are on diuretics, and that's the only single reason why they have the hyponatremia. The other part is, when do you give this drug? We did our trials mostly giving drugs in the morning, doing the ambulatory blood pressure, central aortic pressure, morning surge. But here is a beautiful study. This is in fact the first one that which is prospective, open labeled. They followed up for 6 years, and what did they find? That when you give the ARB in the evening, the sleep time blood pressure reduced, the nocturnal dip was preserved, the morning surge was lesser, and when ARBs were given in the evening time or a bedtime doses, the new onset of type 2 diabetes was reduced by close to 38%. That probably will come back to a theory. Does it matter whether you give a triple combination in the morning or the evening? For convenience's sake, yes, you give it in the morning. We might also say that you have a diuretic, so you don't want the patient to pee often in the night, but that's not true for all diuretics. I mean, their property as a diuretic drug purely for water loss and natriuresis is going to be short-lived. Thereafter, it's all vasodilatation. So, even when you give up a triple combination in the evening, you might get a better blood pressure control, better nocturnal sleep protection, better morning surge, and a very, very effective therapy. So that's what I tried to say. And this trial looked at ARBs and ACE inhibitors, and interestingly, even beta blockers to some extent, when administered in the evening, also helped in the nocturnal control of blood pressure, particularly the sustained form. So this is another concept that we'll have to look at very, very carefully. And lastly, age may not be a primary consideration. Why? When we talk of age and we say, look, here is a young hypertensive below the age of 50 or 55 years. Here is an elderly hypertensive. But on what premises we base it? These are 4. Are we talking about abrupt definable changes in the underlying disease mechanism? Does it represent an abrupt change in the cardiovascular disease risk? Does it predict a demonstrable difference in the blood pressure response to the blood pressure drugs? Or is there a difference in the risk-benefit ratio? Really speaking, no, it doesn't matter. We always felt that the ARBs in the elderly may not work as well, but that's untrue. If you look at olmesartan in 7 studies, in patients who are less than 65 and more than 65, or even you go back to the valsartan studies, they worked equally well. So RAS inhibition works at all age. I'm skipping the escort 2 slides and adding 1 line. If I have to use a combination for the future, I would really, really look forward to a chlorthalidone with spironolactone combination with Professor Roberto Ferrari just talked about, the pathway 2. Mind you, in pathway 2, spironolactone reduced the systolic blood pressure, and the predictor of response was the plasma renin activity. In patients whose plasma renin activity was less than 1.4 nanogram per ml, had the best spironolactone response. What does it tell you? The resistance was contributed by volume load. And when you gave a diuretic that dropped the volume load, got back the vascular reactivity, the blood pressure was controlled, and it was the best add-on drug, as Professor Roberto Ferrari showed, as compared to alpha blocker or a beta blocker. Now you have chlorthalidone, where you have some concerns about hypokalemia, and you have spironolactone or eplerenone, you have some concerns about hyperkalemia. Both drugs are excellent drugs individually. If there is a way to combine this, you might be able to get many more patients under the blood pressure curve. But then you still have AS and ARB, which can increase the potassium. So these are some of my thoughts as to how drugs may get into the combination therapy era. Thank you very much, ladies and gentlemen. Chairman says.
Thank you very much, Uday, for a very fine presentation. I invite our Dr. Venkatram once again, the international expert on hypertension. And he's going to tackle a very important study, the SPRINT study, the NHLBI sponsored SPRINT study. Dr. Ram, please.
Yeah, thank you very much, Mr. Chairman, ladies and gentlemen, again. This is the reason I'm here. I covered for Dr. Chopra earlier. My thoughts on the implications of the SPRINT trial, I will tell you right in the beginning itself, in case I run out of time. If you reduce the office blood pressure to less than 140/90, you have achieved the SPRINT trial targets. If you reduce the blood pressure in the clinic or office under 140/90, that is equal to SPRINT trial systolic blood pressure of 120. So, ladies and gentlemen, the take-home message right in the beginning is continue the goals of treatment that have been recommended in patients with hypertension or comorbidities. You reduce your observed blood pressure to less than 140/90, then you have already achieved the SPRINT trial targets. This is a slide that was loaned to me by Dr. Ferrari's colleague in Italy, Dr. Mancia. He loaned me this slide. Ladies and gentlemen, if we really followed the guidelines, we would not have meetings like this anymore. The problem would have been solved. So guidelines have not succeeded in clarifying the issues. The SPRINT trial, we were hoping it has clarified, but it has clarified partially and not fully, and I'll tell you why. In the American College of Cardiology meeting 2 years ago, I had given this talk that all hypertension guidelines should be relegated to sidelines, and you go back to basics and control the blood pressure in the office or the clinic. You had guidelines after guidelines after guidelines, and there is one more this November. On November 15th or 16th, you will get one more set of guidelines, hopefully final for the next decade. The reason why we are treating hypertension, ladies and gentlemen, is only because of this trial. This is the fundamental trial in modern medicine called Veterans Administrative Cooperative Trial, where they treated patients with hypertension with antihypertensive drugs, or they left them on placebo. You will notice when you give antihypertensive drugs, cause a fall in blood pressure, you reduce cardiovascular events. If this trial was not conducted, we'll still be treating hypertension in a very haphazard and casual manner. Risk. Mind you, no mention about diastolic, systolic less than 140 in the office or the clinic. which means sprint blood pressure of 120. That's all it is. Routine treatment of hypertension properly done is good enough. This is a trial that was not included in many of the guidelines. A very simple study showing that in elderly patients, if you lower the blood pressure to less than 140, you help them. If you don't lower the blood pressure to less than 140, they'll have complications. Very, very simple. You lower the blood pressure to less than 140, they benefit, they live longer. If you don't treat, they are going to suffer. Very, very simple. Now, let me quickly go to the sprint trial. These are the headlines from world newspapers last September, almost 1 year. And you can read these headlines, and all of them point out that a new study has demonstrated that we have not been treating hypertension properly and we have to be more aggressive. Every paper in the world has covered that more aggressive treatment of high blood pressure is needed. And that is sprint. Patients who are older than 50 years of age, they were allocated to a systolic blood pressure of 140 or 120, and they were followed for approximately 3.4 years. And the findings were, when the systolic blood pressure was achieved to 120, there was a remarkable reduction in morbidity and mortality, and NIH issued a statement that this is a life-saving information. Lower is better, American Heart Association. So these are the headlines. This was done in US, and actually it was done in one center before I returned to India 5 years ago. They continued the study. 9,000 patients, half of them 120, half of them 140, and they were achieved. You will notice they were achieved over a period of time, and there was a reduction in primary outcomes, coronary, brain, heart failure, and mortality was also reduced. 210 deaths at 140, intensive 155. So the question is whether the sprint trial would reduce the target for treatment and target for diagnosis of hypertension. That is the question, and I participated in some of these. So the question is, would the next guidelines recommend a systolic blood pressure 120 either as the ceiling or the floor in the treatment of hypertension? In my opinion, not likely. I'll tell you why. Sprint blood pressure was taken in a way that most of us don't take, and Dr. Ferrari actually pointed out how busy the clinics are. Patients were received in the hospital. They were taken to a room. They were seated in a quiet room, dark room for 10-15 minutes. Then they were hooked to an automatic blood pressure machine that's starting blood pressure 5 minutes later 3 times, and then the patient is brought to be examined by the doctor. That is the way the blood pressure was done, unobserved, unattended. So the patient is by himself or herself, nobody is seeing, and the patient is seen later on. That means they have avoided the white coat effect. So there was no white coat hypertension, it was removed, and surprisingly, you would expect stroke to go down much more in the treatment of hypertension, but there were a few events. The stroke reduction was very similar between 120 and 140. The greatest driving force for the sprint was a reduction in congestive heart failure. That means these patients were at risk for heart failure. So the driver of the outcome of the sprint was a reduction in congestive heart failure. And if you use the sprint blood pressure the way it is done, you might want to add 10 to 15 millimeters systolic for the office, about 6 to 8 millimeters diastolic for the office blood pressure. So there is some difference between Sprint and Accord, and I will not go into it. The major problem with Accord was people say it was underpowered. And this was already covered by Dr. Jadhav, that the number of drugs that were needed was more, although he mentioned that there were side effects, but there was no postural hypotension. So it is kind of strange, isn't it? The patient had side effects, but no postural hypotension as aggressive treatment. And patients who had systolic blood pressure 120 were seen more often than patients who had 140. That means they received more careful follow-up, closer surveillance. They had 30% more visits than 140, and I told you how the blood pressure was taken. So what happens is a number of patients were withdrew from the study, in both the arms. A good number of them were not followed, and there were problems with follow-up. And let me quickly go to, this is the thing. The major benefit appears to have been as a result of a reduction in congestive heart failure. Now, the comparison between the previous trials and Sprint is the blood pressure that was taken in the Sprint was very, very unique, and it is commendable, and we should congratulate. Quiet room, seated, darkly lit, patient by himself or herself for half an hour or more, and then you saw the patient. If that is the way you want to practice medicine, the Sprint 120 is applicable. But if you want to see the patients the way Dr. Ferrari has shown on his slide, then you need to add, because they were all attended and observed. Very, very important, because they took away the white coat hypertension. So this is a diagram that I drew, that the blood pressure that was taken in the Sprint, the way you took, if it is 120, it translates to 130 to 136 to 140 in the office. If the diastolic was 76, it translates to 82 to 84. So what does it mean, Mr. Chairman, ladies and gentlemen? The Sprint blood pressures are very important, but they translate to higher levels of blood pressure in the office or clinic. You add few millimeters more. That means the goals for the treatment of hypertension that I have shown in the beginning, less than 140 or 90, should be sustained. Nothing changed, it's sustained. But the problem in the interpretation all over the world is that systolic blood pressure is 120 in the office or in the clinic. But that is not the way it was measured in the Sprint. They took away the white coat effect, and the patient was made comfortable. But if you add white coat effect, which is variable, not predictable, then I think the goals are the same that you have now, namely less than 140 or 90. So in conclusion, Mr. Chairman, ladies and gentlemen, the Sprint data, very important data, are applicable 100% only if you measure the blood pressure the way it was done in Sprint. If you want to do it, then it is 120. And then, if you want to translate it to office, then you have to add few millimeters. And you don't have time for patients to wait for half an hour. And there was no observer in the room, there was no attendant in the room. Patient was seen by the doctor after the above process is complete. So it's a very interesting trial, gives very useful data. But the question is, how do you want to interpret it to suit your day-to-day clinical practice? So, Mr. Chairman, ladies and gentlemen, what matters in the treatment of hypertension is treating the blood pressure to less than 140 over 90 and keep the blood pressure under 140 over 90 continuously with effective and well-tolerated drugs. So if you keep the blood pressure under 140 over 90 all the time, you're already following the sprint results. You're already following the sprint results of that. And lastly, we can't advocate a 120 office blood pressure globally because it is not feasible for cultural reasons, for financial reasons, for public health policy reasons. So I would submit to all of you and to the panelists that the systolic blood pressure in sprint is probably equal to 134, 136, less than 140 in the office, and diastolic you have to add 6 to 8 millimeters. That means the latest guidelines of less than 140 or 90 are sustained, and if you continue to do that, you will be actually causing an affirmation of the sprint trial that even with white coat hypertension, you are achieving the target levels of blood pressure. With those remarks, ladies and gentlemen and panelists, I'll conclude. Thank you very much.
Thank you, Dr. Vakatram, for your excellent deliberations and giving us very important practical insights into the sprint trial, which were not talked about very frequently. Thank you very much. Our next speaker is Dr. Nazir Zuvele. He will be talking on hypertensive urgencies and emergencies, how to react. Dr. Zuvele, please.
Good afternoon, everybody. Thank you, Chairman. Thank you, Brian, for this invitation. Regarding what's hypertensive emergencies and what are the hypertensive urgencies, the term hypertensive crisis is used when the systolic blood pressure is more than 180 and diastolic blood pressure is 110. But what is emergencies? What are the emergencies? Severe elevation in systolic blood pressure with acute target organ damage. The term is acute target organ damage, while absence of target organ damage is called hypertensive urgency. There was another term called malignant hypertension, where elevated blood pressure is associated with encephalopathy and papilledema. Now, this term malignant hypertension entered the medical lexicon in 1928 because at that time the patient with this condition had prognosis which was similar to malignant cancer, 10% survival at the end of 1 year. However, newer improved therapy have improved outcomes, and now it has been shown with the treatment the 90% survival at the end of 1 year. Now, what are in urgency? How do you treat urgencies? Is there a difference in the treatment between urgencies and emergencies? Yes, definitely there is a lot of difference. These are the three questions. How quickly should the BP be reduced? Whether it should be reduced in minutes, hours or days. What should be the BP target? Less than 160/100 or 140/90? How should this goal be achieved? With the oral drugs or IV drugs? The common cause for hypertensive urgency is patient not taking medications and patient consuming excess of salt. What are the problems? Rapid reduction of BP has risk of adverse events like stroke and myocardial infarction. And if you don't treat it properly, there is a potential risk of imminent cardiovascular events and legal ramifications. Now, how do you treat hypertensive emergencies? You need not admit patient with hypertensive urgencies to the hospital. They can be treated in the outpatient department. If you keep the patient in a quiet room, the blood pressure can be reduced by about 30%. Sublingual nifedipine is contraindicated because it has got unpredictable and uncontrolled BP reduction leading to ischemic complication. The drugs used and recommended are oral drugs, oral furosemide, oral clonidine, captopril and amlodipine. What about emergencies? Often the diastolic BP is more than 120 millimeters of mercury, but there is no specific threshold, since individuals who develop an acute rise in BP can develop symptoms if previous BP was normal, such as a pregnant woman who develops eclampsia or a young adult who develops acute glomerulonephritis. So it's not the BP reading, it is the clinical situation and the symptoms which is important in hypertensive emergencies. Now, what are the common clinical scenarios? The common clinical scenarios are mostly neurological emergencies, which could be in the form of hypertensive encephalopathy or cerebrovascular accident like cerebral infarcts, intracerebral hemorrhage, subarachnoid hemorrhage, and the cardiac emergency in the form of acute coronary syndrome like unstable angina, STEMI or NSTEMI, acute decompensated cardiac failure, acute aortic dissection. Now, this is important, this thing, the treatment management completely differs. Acute renal injury, hypertensive emergency during pregnancy, and you should also keep in mind hypertensive emergencies due to catecholamine excess. Single organ damage is present in approximately 83%. That means all the patients with the same blood pressure reading don't develop complication in all the organs. Most of them will have single organ damage, 2 organ damage in 14% and multi-organ damage in 3%. Most common clinical presentations are cerebral infarction, followed by pulmonary edema, followed by encephalopathy. Less common presentations are intracerebral hemorrhage, aortic dissection and eclampsia. The various causes, we need not go into detail about that, but commonly it is medical non-compliance, withdrawal of the drugs and renal disease and sometimes the abuse of drugs. The exact pathophysiology is not known, but what you see there is a luminal narrowing in a small muscular artery. These are the kidney biopsy pictures, and what is seen is a fibrinoid necrosis in afferent arterioles. Clinical presentation depends on which system is affected, and usual signs and symptoms with the patient presents is breathlessness, chest pain, headache, altered mental status, focal neurological deficit, and signs of microangiopathic hemolysis. Patient evaluation. In patient history, you should always ask for whether the patient had hypertension previously and what medication patient was on. Last dose of antihypertensive medications taken and compliance, and recreational drug use like amphetamines and cocaine, because the treatment differs completely. Symptoms are related to target organ. A diagnosis of hypertensive emergency or urgency cannot be made based on a single absolute blood pressure reading, but is based on acute elevation of blood pressure from baseline associated with any organ damage. In the evaluation, this I will skip because you already know there is no specific investigation. You are well aware of these various tests to be done: metabolic pattern, urine examination, ECG, and cardiac biomarkers if acute coronary syndrome is suspected. And amongst the imaging, it depends on which organ or symptoms patient has got, whether it's a CT of this thing. XHS is a routine thing for detection this thing, and for detection of aortic dissection, one has to ask for transesophageal echocardiography. Now, this is the most important slide of my talk, and all of you should understand this. This is mean blood pressure of a person or normotensive. Now, if the mean blood pressure goes up beyond 150, what they can develop is a cerebral edema. If the mean blood pressure comes somewhere less than 50, what they develop is a organ ischemia. The situation is completely different in patient with hypertension. This is called autoregulation. So, in a hypertensive patient, if you reduce the mean blood pressure less than 120 or so, they will develop organ ischemia. And this is how, when you reduce the blood pressure excessively, they will develop either myocardial infarction or stroke or aggravation of stroke. Similarly, a patient who is chronically hypertensive, even if his mean blood pressure is somewhere around 190-200, he will not develop cerebral edema. So, don't get panicky just with the blood pressure readings. Regarding therapy, it is generally unwise to lower blood pressure too quickly for too much, as ischemic damage can occur in vascular beds that have grown accustomed to the higher levels of blood pressure. For most hypertensive emergencies, mean arterial blood pressure should be reduced gradually by about 10 to 20% in the first hour. Mind you, 10 to 20%, and by further 5 to 15% over next 23 hours. So, here your target is not 140/90 blood pressure. Here your target is percentage of presenting blood pressure. So, this is the crux of the treatment: 10 to 20% in the first hour and further reduction by 5 So in 24 hours, you have to reduce the blood pressure by 25%. The major exception for gradual BP lowering over the first day. That means whether you will reduce over 24 hours or when you change your protocol. The number one, the fastest blood pressure reduction should be in the treatment of aortic dissection. And here your target is systolic target of 120 millimeters of mercury in 20 minutes. But if a patient has presented ischemic stroke and he is undergoing reperfusion therapy, then your goal is BP is usually not lowered unless it is more than 180, 110. If the BP is more than 220 by 120 in a patient, then you have to reduce the blood pressure. These are the amongst the patient who presents with stroke. If he is going for reperfusion therapy, his BP has to be somewhere around 185, 110. And if he has got a very high blood pressure, then he has to be, his blood pressure is to be rapidly controlled. All these emergency situations, they require patients to be monitored in ICCU, and if you are going to use nitroprusside, then the patient should have an intra-arterial line. There are various drugs available in the treatment, but unfortunately, we have got very few of them. In India, what is available is sodium nitroprusside, nitroglycerin, and enalaprate. Now, this particular drug, enalaprate, is available, easily available, but it has got a certain, it's a slow, its onset of action is slow, but it has got an unpredictable and excessive fall in pressure, can precipitate acute renal failure in patient if you have got a bilateral stenosis. Now, most of you know about sodium nitroprusside. This is effective in most of the conditions, but these drugs are to be used judiciously. Nitroprusside and nitroglycerin cannot be easily missed, should not be, they are not the first drug of choice in the management of stroke and hypertensive emergencies. Nicardipine is one of the very good drug. Unfortunately, this is not available, and this will be a drug of choice sort of thing in the management of strokes and most of the emergencies, except patient with aortic stenosis. Now, nicardipine actions are exactly same as nifedipine. I don't want to go into detail about what the side effects of these various drugs are. Most of you are well aware of that. And the next option what we have got is labetalol beta blockers, labetalol, metoprolol, and esmolol. Now, these are the short acting. This onset of esmolol has got a immediate onset of action. Labetalol is to be given in the dose of 2 to 80 milligram as slow IV injection over 10 minutes. The dose can be either repeated every 10 minutes in the same dosage. One can go up to 300 milligram, or one can start an IV drip of labetalol. Now, you know the usual contraindications about these drugs, but beta blockers should not be used as the first line of treatment if you are suspecting abuse of drug, like cocaine toxicity or patients who are on amphetamine, because this can have unblock alpha receptors and cause havoc. Phentolamine is the drug of choice in that situation. Now, this is also used when there is a catecholamine secretion. Hypertensive encephalopathy, as I said, sodium nitroprusside can increase the intracranial blood pressure. Nicardipine, labetalol, clevidipine, and phenoldiazepam are the drugs to be used. Cerebral infarcts, rapid decrease, as I said earlier, should be discouraged, and permissible hypertension is allowed for 24 to 48 hours. Intracerebral hemorrhage, again the most complicated thing. Severely elevated BP may worsen intracranial hemorrhage by representing a continued force of bleeding, causing hemorrhage expansion and potentially worsening the outcome. While an increased mean arterial pressure may be necessary to maintain cerebral perfusion, and lowering BP below 130 millimeters of mercury may cause ischemia and worsen neurological deficit. So, if a patient has got intracerebral hemorrhage and his BP is more than 200 millimeters of mercury systolic, aggressive reduction of blood pressure. Aggressive reduction means there are trials which have shown that if you reduce, you might have to reduce the blood pressure by 140 or so systolic. While if the systolic BP is more than 180 in patients is not suspected to have elevated intracranial pressure, that means patient is fully conscious, you don't measure intracranial pressure usually, then you might keep a target of moderate target of 160 millimeters of mercury. While if the patient has got elevated intracranial pressure, then one might have to measure the intracranial pressure and guide the therapy accordingly. Treatment of subarachnoid hemorrhage, optimal therapy is not clear. 2012 guidelines tell you the systolic blood pressure value of less than 160 millimeter of mercury. BP control is necessary. Use of vasodilators such as nitroprusside or nitroglycerin should be avoided because their propensity to increase the cerebral blood volume and therefore intracranial pressure. Cardiac emergencies, dissection of aorta, the drugs of choice is IV nitroprusside and labetalol or any beta blockers, and this has to be, the BP has to be lowered within 20 minutes or so. Acute coronary syndrome, you are well aware of this drug, nitroglycerin and labetalol. Acute heart failure also, the nitroglycerin and this thing, nitroglycerin, these are the drug of choice apart from the diuretics. Acute kidney injury, the drug of choice here is phenyldepam. Now, the phenyldepam is the only dopamine agonist which improves natriuresis, diuresis and creatine kinase and currently preferred drug of choice. Yeah, pregnancy, I know it's 1 minute. Pregnancy is all controversial. Only thing, there are various guidelines which have given various blood pressure readings. 160 and 110 requires ICU admission and your target should be somewhere around this. Various drugs have been used, but sustained release oral nifedipine 30 milligram has been approved and that also can be used. Emergency, as I said, in catecholamine excess, you should avoid using beta blockers and alpha blocker is the drug of choice. In summary, differentiate hypertensive urgencies from hypertensive emergency on the basis of end organ damage. Can treat hypertensive urgencies with oral medication and on OPD basis, but ICU admission and parenteral medication is required for hypertension emergencies. Aim is to reduce BP by 25% over 24 hours in most of the condition, and don't forget to start oral medication and follow up. Thank you.
Thank you, Dr. Juvele, for really doing a great job in covering this huge subject within 15 minutes. Thank you very much. We are left with one or two questions if may be allowed from the audience. Yes.
Sorry. I want some small clarification from my dear friend Professor Ram. He mentioned that missing of a dose, telmisartan or olmesartan, I wanted to know whether it was for a day or more than 1 day. Professor Ram?
Yeah, very quickly, it's only to illustrate the utility of 24-hour BP. That was missed for 1 day, but there are studies suggesting up to 2 to 3 days. If you miss, the blood pressure is maintained, but one would not advocate it.
Because for 1 day, if patient says, I say, don't bother about it.
Long-acting drugs. For long-acting drugs.
Another thing Professor Uddhav mentioned was that you should give the dosages in these medications in the evening rather than in the morning. What is your opinion? What is the opinion of the house?
Yeah, that's a reasonable thought process that you might want to give a RAS inhibition in the evening hours. That's not a guideline. Not necessarily a recommendation.
I have been advising my patients to take it in the morning.
So nothing wrong in that too. So that's perfectly okay.
We call it chronotherapy.
Absolutely.
Because the action is 24 hours.
Yeah, but I showed you the data, sir, of these new studies, and a lot of interest has been created these days, including ambulatory blood pressure monitoring reports, that if you give a RAS inhibition in the evening, you might get a better control, lesser morning surge, better nocturnal dip, lesser new onset of type 2 diabetes. So
third small point, the nifedipine sublingual, one professor said that it should not be given. Because see, other drugs take time and the patient wants, we have been given in casualty and all that, telling our houseman to give it.
Absolutely.
What is the opinion?
Absolutely contraindication. The drug has not been approved by FDA and it causes increased mortality. Suddenly, unpredictable effect of this particular drug, blood pressure will suddenly come down from 180 to 90 or so, and the patient will end up with either stroke.
It's very rare to come to 90.
No, but it is not absolute contraindication. Sublingual nifedipine liquid form is not recommended at all.
Actually, Professor Friedberg published in 2003 what Dr. Nazir said. I mean, looking at the guidelines, no, you should not use it.
Absolutely. I just have a small comment to make about resistant hypertension. It was very interesting to know that in Simplicity 2 trial, there was a criticism that all the patients did not receive spironolactone. Only 17 patients received it. And they refused to call it resistant hypertension. So that brings us to the fact that many of the so-called resistant hypertension have a bilateral adrenal hyperplasia. And using mineralocorticoid receptor blockers, or for that matter, potassium-sparing diuretics, go a long way in addressing the problem. So probably the definition could include the potassium-sparing diuretics instead of only diuretics as the new definition for resistant hypertension.
To Dr.
Thanks.
Venkatram,
If I can make two comments relating when to provide the drugs for hypertension. Probably not everybody is aware that in the HOPE trial, which was a landmark trial, ramipril was given at night and did results in extremely strong cardiovascular protection. And as a cardiologist, to me, it does make sense to use an ACE inhibitor in the night or a drug to reduce blood pressure, considering the majority of the infarct are in the early morning, and perhaps you can control better hypertension.
Uday,
I would like to make...
You said that
okay.
the night dose has reduced the new onset diabetes by 32%. Is it compared to the morning dose and the night dose? That is the same ACE inhibitor used in the just change on timing.
Yes.
That's
And let me also add.
Interesting, and I think very
absolutely,
to use in the night. I think the new onset diabetes Indian scenario. And at Venkatram, you mentioned the sprint trial. The white coat phenomena was taken away in the sprint trial. But the white coat phenomenon is not a universal. See, many people don't have any change in the blood pressure, even after 10 minutes, 15 minutes, many 80%. I think only 20% people have a white coat. So your 140/90 target of his BP, allowing them with is really true, because this white coat is not a universal phenomenon, sir. There are large people who don't have any change, in spite of making them to sit quietly and that thing.
So let me add to what Professor Roberto Ferrari said. The HOPE study, sir, Dr. Sainani, had also a sub-study of the ambulatory blood pressure monitoring, and ramipril was given in the evening, and the event reduction was very significant. So I think there is a theory that probably.
Uday, I have one last comment to make. I think this is the first time that I have heard panelists and people who have been talk about the real world. Everybody talks about esoteric trials and so on and so forth, which are wonderful. But Dr. Ferrari and Dr. Venkatram, I congratulate you for bringing it to the attention of this audience that the real world is where we practice medicine. Okay? And I think your points are very well taken and very valid, and that should be the take-home message of this thing on hypertension. Thank you very much. Okay, I would like to thank all of you for being here. Dr. Venkatram, Dr. Ferrari, Dr. Uday, Dr. Nazir Juwale, thank you for your wonderful presentations. Extremely well done. And thank you, the audience, for some very active participation. I think we'll break for lunch now. Thank you.
Short break for lunch, and just a reminder that we will be starting our academic feast back at 2 o'clock. We are keeping to time, so please be here by 2. Thank you. 25 minutes.